We are live.
Good evening, everybody, and welcome to this webinar that is on the, I would say, a relatively newer paradigm in refractive surgery that is called as small incision lenticle extraction, or SMILE. Though this has been around for the last decade, I will say there are lots and lots of new things that have been added. And as a technology moves on, there are really very interesting things that are happening. Now, when we look at laser vision correction, as you all know, laser vision correction started with PRK, and then the game changer that came in was the blade or the keratome LASIK that was there. And from there on, in the early 2000, around 2004, we got the femtosecond laser, which was used to make the flaps, and we got the femto LASIK platforms that were available. And then there were also innovations on the way the excimer laser is applied onto the corneal bed to give it better outcomes. There came in the Eagle Vision, the customized LASIK, the Xioptics, etc. But I think the paradigm shift that has happened is that the surgery has now become flapless. And as we see that this surgery, which is a flapless surgery, this is a bladeless flapless surgery, which is SMILE, as it has caught on the fancy of the ophthalmic surgeons, and now it is approved all over the world, including the FDA approval, which was the last to come. It is taking the other companies also into the lap, and almost all the companies are working on getting their equivalent of SMILE. Some have got CE certification, while others are working on phase 1, phase 2. And I think it will be over the next 2-3 years that we will have other companies that will be coming on into the gamut of SMILE. So today we have this webinar that is going to talk about the science behind SMILE, as to how it is shaping up, what are the results that are there, what are the new things that are happening, how it is possibly safer, what are the advantages of SMILE, what is the science behind SMILE. And then from there on, we'll be talking about the newer research that is happening in the era into the total gamut of SMILE. The session is broken up into a second part. The first part is the clinical part, and the second part that we have would be divided into the commerce and how does one get the best results, how does one reach the patient, and how does one convert the patient to this grand technique of SMILE. So we have with us a galaxy of speakers, and all of them are very well versed with the procedures, the technique, and the technology of SMILE. And we have a great panelist who will be discussing, and we have again in the panel people who have had a lot of personal experience as regards SMILE. So Dr. Namrata would do the introduction, but I wish to thank particularly Professor Jodh Mehta from Singapore, who is joined, and he is, as you all know, at the SNEC. He is a great cornea surgeon and a great refractive surgeon and at cutting edge of technology. Amongst the other speakers who will be introduced, we have Dr. Garewal, we have Mrs. Shroff, we have Ms. Weber, then we have Dr. Tityal, we have Dr. Ritika Sajdev, Gitansa Sajdev, myself, and Rohit Shetty. So among the panelists, we'll have Dr. Ramamurthy, whom you all know has been the past president of AIOS. The introduction will be given by Namrata. We have Dr. Rupal Shah, Gaurav Luthra, Dr. Kudlu, and Dr. Vardhaman Kankaria. So we have all of them, and they will be open to questions from any of the audience. So please put the questions, and we will be having a lively session where you can have interactions with all of them. So without much ado, I'll pass on to Dr. Namrata Sharma, who, as you all know, is the Secretary of All India Ophthalmological Society. She is the Professor of Ophthalmology in Cornea, Refractive and Refractive Surgery at RP Center, All India Institute of Medical Sciences. So Dr. Namrata, maybe you can introduce the speakers, and we can start the session rolling. Thank you.
It is my privilege to introduce the first speaker of this webinar, Professor Jodh Mehta. I think we all know him. He's been in a lot of our scientific sessions. He's the senior consultant at the Cornea and External Eye Disease, Cataract and Comprehensive Ophthalmology Refractive Surgery Program at SNAC, Singapore National Eye Center. And he is going to be talking about an important subject that we all should begin with, and that is science and smile. So, Dr. Jyoth, over to you.
Thank you, Namrata. Thank you, my pal, for the kind invitation to take part in this symposium. So I'm just going to share my screen. Okay. Okay, that's okay? The screen's there? Yeah, okay. So, so thanks for the invitation to take part in the symposium. So I'm going to be talking about in the science and smile section, and I chose basically one topic which I think is quite interesting, and I'm going to really talk about this in a lot more detail, and I think it's relevant to all of us, and this is nerve regeneration following smile. These are my financial disclosures. So, of course, we all know small incision lenticle extraction, which is the acronym, is a small incision keyhole surgery where lenticle is basically extracted through incision, and it's probably the end point of lenticle extraction surgery. And there are lots of advantages when we see these basically smaller surface wounds. Theoretically, certainly the eye can be biomechanically stronger. There's this issue of any sort of rupture to the flap in patients doing sports or sports-related activities in which there's a chance of getting injuries. And of course, one of the big advantages is they should provide you with a better ocular surface because there should be less issue with dry eyes. And these are patients on our RCT. On the right-hand side, you'll see a typical LASIK flap. On the left-hand side, the patient basically in the left eye had smile. And typically, when you see these eyes at 1 month, you'll see typical punctate inferior epitheliopathy staining on the LASIK eye, and you don't really see that with the smile eyes itself. You get a slight reduction in a tear breakup, but you see a generally better ocular surface. So it tells you that the ocular surface is slightly better with the smile procedure compared to what we see in LASIK. Now, about 6 years ago, we looked at this in detail in an animal study, and what we're able to show is that over an 8-week period, when you compare the nerve regeneration in LASIK, you can see in the top compared to smile at the bottom, you had a faster regeneration of your nerves in the smile eyes compared to what we saw basically on the LASIK eyes. And these were matched for the same refractive error. One eye of the rabbit had smile done, one eye of the rabbit had LASIK done. So what we basically noticed was that at 1 week, you had a reduction in subbasal nerve plexus in both groups, but you had faster nerve recovery in the smile eye compared to what we were basically seeing in the LASIK eyes. The other thing that we also noted on in vivo confocal microscopy is that the morphology of the nerves was very different between the two groups as well. With LASIK, typically we saw more sprouting nerves like you can see over here, which is indicative of nerve regeneration. And this is one of the thinkings that gives you the hypersensitivity sometimes you can see basically with LASIK patients. But with the SMILE group, what we noticed was there are much more longer nerves of normal basically nerve morphology. So basically the nerves that regenerated seem to be morphologically much more normal. Subsequently to our paper, there was a whole gamut of basically papers published from clinical literature from 2014 up to about 2015, 2016. And if you look at the results from this, when you're comparing SMILE to LASIK, you'll see most of these studies basically showed improvement in outcomes, whether you're looking at Cochet-Bonnet, OSDI, Schirmer's tear breakup time, or even in vivo confocal microscopy in favor of the SMILE eyes compared to those of basically the LASIK eyes. So it showed basically what we saw in the animals was basically what we were seeing in the patients as well. Now, if you look at the nerve regeneration following refractive surgery, you will see that basically, typically with PRK and LASIK, of course, you have this immediate denervation at 1 month, but over sort of like 1 year and then basically 5 years, you'll see an improvement in the innervation on this side. Now, typically in SMILE, you can see over here in the green bar over here, you get less denervation in that first month period. But most of the literature has really focused on just the 6 months. So often people ask me, well, what's happening basically after the year in the SMILE eye? Does it make a difference that you haven't got so much denervation in the first month if basically by 1 year, the LASIK eyes are basically catching up? And does this early denervation make a difference in the long term? I mean, are you going to basically still have this advantage at 5 years? Or do we just tell our LASIK patients, okay, the SMILE eyes are basically going to be better at 6 months or a year, but basically by 1 year, you guys should basically be equal in both sides. And this is what we basically aim to investigate and study with this study that I'm going to basically be talking about. So recently we published a randomized controlled trial. This was a study that's published in ophthalmology, looking at 70 patients with RCT with 1 month follow-up. They were very specifically randomized with specific spherical equivalent refractive error in basically both outcomes. And you can see the outcomes of the LASIK eyes on the left and basically the SMILE eyes on the right-hand side. So there was no statistical difference in basically the outcomes. I mean, the study was powered to look at refractive error, but interestingly, what we noted is that over the year, the SMILE eyes changed less than basically the LASIK eyes with respect to spherical equivalence. But this gave us an invaluable data set of patients that we could basically look to for other basically studies. So what we did is that the randomized control study started in 2012 to 2016. These are the parameters that basically we stuck with back when we were doing this in 2013. We used femtosecond laser flaps at 120 depth. SMILE caps were basically kept at 180, and the incision size were basically 2.8. So this is not what I do on my current SMILE, but that's what we were doing basically back in 2013. So what we did was we brought these patients back for follow-up. So typically they were split into two groups. The mean follow-up was 4.1 years. The group one basically had an average follow-up of 2.7 years. And most of these cases were done between 2014 and 2016. And group two, with a slightly older cohort, they were done between 2014 and 2012. And they basically had an average of 5.5 years follow-up. So we basically got these patients back. They underwent in vivo confocal microscopy, examining the central, superior, inferior, temporal, nasal quadrants. We then basically imaged them in detail. We used software, which I'll talk about a little bit over the next couple of slides, to basically analyze the nerve regeneration. We also compared them to 6 age-matched normal subjects to see whether the nerve regeneration went back to normal. And as you know from in vivo confocal microscopy, remember, you're only looking at a 400 micron square view when you're imaging basically the nerves as well. The patients also underwent clinical assessment. This was done with Schirmer's type 1, Oxford scoring, fluorescein CFS staining, sensitivity with Cochet-Bonnet, NIBUT, and ocular surface disease OSDI questionnaire. So the first thing was how we were going to basically analyze these nerves. So what we did is that we tried to validate some software that is available online. One is basically called CC Metrics. And what you can see on the left-hand side in A is typically a picture of an in vivo confocal microscopy of basically a nerve plexus or nerves in the stroma. Now, if you look at B, what you'll see is that you'll see a manual mode of the CCM Matrix software where you could basically have to manually track basically the main nerve branches, which are in red, and the branches basically in blue. And where you see a trunk branch coming off the main branch, green dots. So this has been done by basically hand. On the right-hand side over here, you'll see in C, which is done basically with ACM, which is an automated software from the same basically company as well that developed the manual software. And this is all done basically by a computerized system. But you can see that sometimes with the automated software, where you can see these arrows are, you sometimes miss a few of the nerves on this side over here. So we wanted to basically find out how accurate this software was before we started testing this on our cohort. So we took 1,700 images from 20 patients, and the information that you typically get from the basically CCM matrix is basically 3 parameters. One is CNF5FD, which is the corneal nerve fiber density. One is corneal nerve fiber length. And the third thing is corneal nerve branch density. And this is either be the main fibers branch density or basically be the total amount. So what we can basically see from this data was when you compare the ACM metrics, which is the automated system, versus 2 observers who basically were doing the manual system itself, you'll see that generally ACM metrics for all these 3 parameters generally underestimate compared to basically what the observers were getting. So you can see examples over here. This is mean and standard deviation between the 2 observers. When you look at the intraclass coefficient and you look at the variation, you can see that actually it was a lot more accurate basically for the nerve fiber length as well as nerve fiber density. And these results were much less accurate basically for the branching density. So you're good at basically distinguishing nerve fiber lengths themselves and density, but there was variation between the 2 observers as well. And also comparison, when you compare to the automated system, there was also a significant difference as well. But these scores are not so bad, about 0.78 and 0.8 are basically quite good coefficients with respect to accuracy. When you look at basically comparing the observers, at the top, you'll see intra-observers. So the mean bias of the intra-observers was actually quite low, as you'd expect. And this is shown in the equivalent Bland-Altman plots on the right-hand side. And when you look below over here, the inter-bias was basically much larger. So what this tells you is that if you're going to get different people analyzing the software data, you're going to get a larger variation in basically your outcome. So ideally, when you're doing the patients, you want one person to basically do all the analysis if you're going to basically do it by hand and not basically use your automated system. When we compared the manual to basically automated system, You can see on the right-hand side, when you look at the correlation function over here, the solid line is the line of best fit. The dotted line over here is the line of equivalence. What you can see is that generally the ACM matrix, the automated system, generally tended to basically correct compared to what we were seeing in the manual. When there were less fibers, this was less of an issue. But as the fiber density got basically more, you can see that the automated system generally tended to underrepresent compared to what we were basically finding in the manual system. So what that shows you is that you cannot switch between manual grading and automated grading. And there were some deficiencies in the automated grading system that we had to basically be aware of. So we go back to the study. So what we did was because we did this pilot study, we knew that we had to only use one observer. These are the 4 parameters that basically you get from the manual basically programming. And we also wanted to look at sprouting nerves per frame and also beating nerves per frame. So this was done by one of the medical students that was attached to us during the COVID time. So she spent a long time basically looking at these images. Using the automated software, you get those 4, plus you get additional 4 data. You get branch density, you get fiber width, you get fiber area, and also you get fractal dimensions. And if you have a high level of fractal dimensions, you mean you have a higher basically nerve morphology. And these are some of the examples of our patients in the 2 groups. This is basically LASIK at the top, SMILE in between, the control group in E, and some sprouting basically coming off the corneal nerves over here that typically we saw in both the refractive surgical groups that we didn't basically see in the normative control groups. So what do we find? So what we found is that when you actually look at clinical parameters based objectively and also subjectively, there was no significant difference clinically when you assess these patients with respect to clinical assessment of the ocular surface in the SMILE or the LASIK group. And this is basically at 4.1 years basically follow-up. However, when you start looking at the in vivo confocal microscopy, you can see over here in dark images, the ones that are basically clinically significant. The post-LASIK eyes has significantly less corneal nerve fiber density, corneal nerve fiber layers, branching density, and total basically branching depth at a mean basically follow-up of 4.1 years. The other thing that we basically noticed is that the SMILE group had significantly less beading. And what beading means around the nerves is the beading is a response to nerve damage where you get a focal basically enlargement of the axons itself. And it's much more common where you have greater areas of basically subbasal nerve plexus. And we saw more of this in the LASIK eyes compared to what we saw in the SMILE eyes. When you break it down by groups, so remember the first group of group 1 is 2.7 years compared to 5.5 years, and you compare the groups, you'll see an improvement in the nerve fiber density, the branching density and fiber length between the 2 groups, between 2.7 years and 5.5 years. So what this means is that even up to 5 years out, you're still getting significant nerve regeneration in your SMILE group compared to what you're seeing in basically 2.7 years as well. However, when you compare to age-matched controls, these values were still significantly lower, even at 5.5 years. When you look in the LASIK group, again, we saw a similar trial where you basically get an improvement where you compare from group 1 basically to group 2 from going from 2.7 years up to basically 5.5 years. And likewise, you still have a more sprouting nerves even at 5.5 years post basically refractive surgery, showing you still getting active regeneration. And again, these are significantly different and significantly lower than what you see in basically age-matched controls. So what about when you compare the 2 procedures? So when you compare the 2 procedures, what you see at 6 months, you also see at 2.7 years, which is basically that SMILE has significant better nerve fiber density, branching density, fiber length, and total basically branch density as well, compared to what you're basically seeing in the LASIK group. But when you see these at basically 5.5 years, you'll see these parameters and these numbers are getting much, much closer, but SMILE still has an advantage at basically 5.5 years in nerve fiber density and also basically in branching density. And the other thing that we noticed was the beading is significantly less in SMILE compared to LASIK. So what it means is that the nerves are regenerating are much more normal in the SMILE group compared to what we're basically seeing in the LASIK group. Now you can see from this chart here, this shows every single case itself. Because it's contralateral eye study, you can basically do a curve like this. You can see all these results above basically favor SMILE, the ones below basically favor LASIK. And interestingly, most of the groups you'll see in basically group 1 are in favor of SMILE. You have the odd one basically below over here that basically favor the LASIK. And these 2 ones over here are interesting because these ones, when we look into detail, are basically patients from the low myopia group where you expect your nerve regeneration to be faster. And lo and behold, it's actually a little bit faster in the LASIK group compared to what we saw in the SMILE group. So LASIK patients that had better nerve fiber density, branch density, and fiber length were all in the low myope group. The average was about 2.5 diopter correction. So what about in correlation to spherical equivalent? So when you compare the results of nerve fiber density to spherical equivalent, what you can see in the high myopia group, group, you had significantly lower nerve fiber density in moderate to higher degrees of myopia compared to the lower myopia groups. That's a greater than -6 compared to less than basically -6. And the nerve fiber density was 9.3 versus 14.8. But this difference we did not see in the SMILE group. So if you look at basically figure A over here, you see the line is absolutely flat, while the beta over in the LASIK group over here, -10 is on this side, -2 is on this side itself. So you have a much lower nerve fiber density in the high myopic group compared to the lower myopic group. Again, basically showing the advantages with respect to nerve density of lenticular extraction versus basically a LASIK procedure. So in conclusion, published clinical studies have shown advantage in nerve reinnervation in SMILE compared to LASIK only in the short term. Most of the studies only have follow-up to 6 months. This cross-sectional study in a refraction match population showed that there was no significant difference in clinical parameters between SMILE and LASIK with respect to Schirmer's, corneal sensitivity, Oxford staining score, and NIBUT at a mean time of 4.1 years. However, on IVCM, you can see there's significantly less corneal nerve fiber density, branching density, fiber length, and total branch density in the LASIK group compared to the SMILE eye. So the LASIK group still don't even catch up, even basically by 4.1 years. And also you have significantly more beading in the LASIK group than in the SMILE years. Even at 5.5 years follow-up, the SMILE patients had better basically in vivo confocal microscopy images with respect to nerve density compared to the LASIK in the majority of the eyes. The only group that was even close were those basically of low myopic patients, which basically showed slight improvement in LASIK basically over SMILE, but these were basically much more comparative, but they were still basically less than our age-matched controls. Thank you for your attention.
Thank you very much, Jodh, for an excellent presentation on corneal innervation and the parameters as regards the tear function for SMILE and LASIK versus control. We'll have the questions after the talk. I think there is a slight change. We have the next talk by Dr. Rohit Shetty. Namrata, could you just introduce Dr. Rohit?
Dr. Rohit Shetty is consultant, cornea and refractive surgery, vice chairman, Narayan Nethralaya, Bangalore, and of course, he's into research. He's changed the way the research, especially for the Indian continent, and he's going to be talking about advanced matrix and imaging to evaluate refractive outcomes.
Thank you, ma'am. Can you hear me?
Yeah. Yes.
Thank you, ma'am, and thanks, Maipal sir and AIOS for this opportunity. My talk is on advanced metrics and imaging to evaluate refractive outcome. These are my financial interests. I do receive grants for some of the works on Zeiss research. When you look at a cornea like this, there are various things which go into understanding the corneal dynamics, and all of them have an important role in playing how the refractive surgery works. The work, the epithelium, the nerves. It was a brilliant talk, Professor Jodh. I think I'm going to take some slides from my work. Is also something similar. Both of us share the love for confocal microscopy and how the ocular surface diseases. So in the advanced format, I divided it into 3 formats, 3 divisions, basically epithelium, confocal, and the tear film metrics. Very nicely explained and beautiful presentation on nerves have already been done, how the nerves innervate. Basically, what I'm trying to create is, for the last few close to a year, we call it as a nirvana study. This whole thing is about how nerves impact refractive surgery, vision, aberration, and neuroregeneration and adaptation. Basically, each and every word is important in refractive surgery, including how you adapt to a new environment. So this is something which I'm going to discuss today. This is what an optics of a tear film is optical scatter, something like your abrometer, the point spread function of your abrometer. And you can see that with the dry eye and with the dry eye, and you can see how much the scatter is. So it gives you the entire time your tear film from the first blink to the last blink, how the tear film is. And you can see that anything which is stable here, then this means that your tear film is stable. This is a classic problem with refractive surgery, which all of us to be aware of. What happens to your tear film when it breaks? And this is a break which you feel and you can see that the vision drop is significant compared to this here. So it means that These patients may have a very perfect ablations, well centration, but your scatter and light could be coming from here. And this applies both in refractive surgery and as well as in multifocal IOs. And this is something which is not the domain of my talk, but what I want to say is a poor tear film actually causes a very poor depth of focus. Because what happens is when you have a tear film which is breaking, it's very difficult for your accommodation to sustain. So there's always some amount of accommodative lag or accommodative excess which happens, which creates a depth of focus issue. So a tear film like this could have a different depth of focus compared to this. So when George mentioned about nerves and quality and your T-buds and Shermers, it's just about having not only a good ocular surface, it's about having a fantastic depth of focus. And this is something I think as ocular surface specialists, we should understand. When your tear film breaks, the eye focusing, refocusing changes a lot. He's mentioned about the nerves, but I'm going to talk about not the nerves here, all these dendritic cells and the microneuromas. You don't really pick them up. These are all patients who are coming with contact lens intolerance, who are not happy with the surgery, with their contact lenses. So when you actually do a surgery on a perfect nerve, and this is what you get, the patient is comfortable post-op, happy person, and your quality of life is perfect because everything is good. Now let's look at when you do a laser, flap-based surgery on these patients. These are all unhealthy nerves. You end up with more inflammation. The epithelium irregularity is more. Molecular tear film is bad. And this is what happens. They're never happy. And the quality of life suffers. And this is why it is very important what George mentioned, how do you protect your nerves. Let me look at these two pictures. There are patient 1, 2, and 3, the 3 different types of patients. And this is a good ocular surface, moderate, and this is something which is not good. I can see the nerves, inflammation. You can see the difference between this and this on the corneal nerves. Let's look at these two patients. One underwent a flap, other one underwent a smile. I mean, we did not really divide them, randomize them. It was just at that point of time, it was not a study where we would intervene and change the procedures. This was the pre-op epithelium. If you have a bad ocular surface, your epithelium is unhealthy, and you do a surgery, and the regeneration is extremely poor. This is what George mentioned about it. Look at the regeneration in a patient who had very poor ocular surface, a lot of nerves, and here it is slower, but over time, maybe a year and a half, 2, it starts regenerating. The nerves are slender. It's not as thick as what it was pre-op. And what is important here is the hemostasis between an epithelium and the nerves. If the nerves are unhealthy, so is your epithelium. And you can see that this is why SMILE has a different feature. It's just not preserving nerves. It's not about dry eye. When I say advanced metrics, you look at nerves and epithelium as a complex because the nerves maintain the hemostasis of an epithelium. And if you have a perfect epithelium, if you have a perfect nerves, you have a perfect epithelium. And a perfect epithelium gives a good tear film, and you can see the difference between the tear film of this versus this. And the most important thing is you end up in very healthy, very happy patients. And this is what happened. This is what we see. These kind of nerves is what we see in more than 22% of our patients. And we do not really put in efforts. A poor meibomian glands is again a factor. So when you take this patient for a LASIK, you may get 6/6, you may get 20/20 vision, but you're never going to get the quality of vision what you want because it is affected by your tear film, the epithelium, and multiple factors. The second important thing is the topography itself. We all used to a certain set of Scheinflug imaging, but now what I feel is in the modern era of refractive surgery, one of the topographers, OCT-based topographer, I'm very, very passionately loving it is the MS39. It gives you epithelium, it gives you epithelium, it's anterior stroma, and it gives you at the Bowman's. And that is the beauty of it because you're actually virtually subtracting the epithelium. Look at this. This looks suspicious on a pentacam. All your indices are normal, but this is actually an epithelial change and your anterior elevation, but in your Bowman's, it's normal. And your epithelium, it gives you an epithelial cylinder of around 0.4 diopters of cylinder is coming from the epithelium. That means this patient's epithelium is inducing a 0.4 diopter. And if you are treating this on your topo-guided, Contura, one of them, you have a lot of issues because epithelium would change post-surgery. Exactly the same thing. This looks suspicious, but your indices are normal. And you see that exactly at the same point, you see an epithelial change. Anterior elevation is there, which matches with your pentacam, but your stroma is normal. That's because this is coming from the Bowman's layer. And this patient again has close to around 0.4 diopters of epithelial change. So it's very important to understand the connection between the nerves and epithelium. And this is very important. That is why even though this patient has an abnormal looking topography, your indices are completely normal because the cornea is strong. It's not a weaker eye. And this is in keratoconus, just an example of how much the cylinder can compensate from the epithelium. We spoke about the Bowman's. Bowman's layer imaging is very important. There were not many tools. This was something which we published about in the beginning stage, how you can have a Bowman's wrinkle. But the modern day OCT can pick up your magnified view of your wrinkles in your Bowman's, and that can translate to your quality of vision. And this can translate your quality of vision. So in the advanced metrics, you can even pick up your early Bowman's wrinkle, and this has a huge impact into your quality of vision. Coming to the biomechanics, there are new indices called SSI indices, which looks at a completely independent of your thickness, completely independent of your IOP. And this is important is that it's independent of your PACI and IOP. This is from the Corvus. We use this method and we use some prediction methods now. And this is something which is important is we want to come out with a software which is already ready, where you can feed in your data and it will tell you which of the procedures will actually give you what type of biomechanical change. And we should be launching it shortly. This is an software where, before you do a surgery, you can fill in your pentacam data and your Corvus data. It does its own modeling and tells you if you do a PRK, it gives you this much weakness. And this is important because you can choose between procedures. The question always comes is in SMILE, we always talk about SMILE Extra. Does it work? And we started looking at using polarization sensitive OCT to image the collagen. And we have mentioned about this. This is how a collagen looks. And you can see that when you have these areas which loss of signals are something which is where it's weaker. Let's look at these patients who are suspicious. And you can see that this collagen is much normal compared to here, where you have a loss of signal, and this matches with what you see inferiorly here. So this picks up early changes in your collagen, but also helps us to understand what happens when you do on this patient who has a corneal weakness. And you can see that SMILE Extra actually makes it look more like a normal collagen compared to, what you'd see if you're just done without a SMILE Extra. So, and also some new indices like SSI looks at whether the cornea is becoming stiffer or weaker. This is just some images about the changes here. What are the future directions are about looking at newer molecules, comparing the imaging and trying to see what new molecules you can find out from your tissues. And what we've been doing is we're collecting every lenticule, but we're imaging it with the polarization sensitive OCT so that we match what you see with your molecular signatures. And sometimes it matches, sometimes your collagen matches to what you see here. Sometimes it does not match. So these are all the future advanced direction in which we are looking in the SMILE. And these factors will probably one day be part of a system. And I'll just skip these two slides because it's the same slides. Why is it important is because we're looking at a lot of diseases are getting into gene therapies. Today we are doing a SMILE Extra. Tomorrow we might have a system where you can enhance the collagen by itself. This is what we had shown a few years back. But this is the first image of a mouse. We did it in the COVID time. This is an animal imaging lab where we did a early gene therapy using drops on the mouse model. And we just got very exciting results on it. It is just using a drops here. So future of imaging is mix of very advanced tools. We look at the confocal microscopy, epithelial mapping, new imaging to look at the collagen itself. And you have to combine it with molecular signatures. And finally, the predicting model which is a software base which looks at multiple aspects of a disease. So my topic was advanced imaging. So I use all that which I can find in advanced prospect. What is interesting is the time is very fast. What is advanced today, what is very advanced today becomes very ordinary tomorrow, because time moves fast, everything catches up very fast. These technologies, without our knowledge, will be in our clinics very shortly. Thank you.
Thank you very much, Dr. Rohit. I think, Rohit, can you stay back for some time? I hope you're not leaving immediately.
No, I'm here, sir.
Let us just take the both the talks of yours and Professor Jodh are looking into the science and as to how things are as regards imaging and science. But let us also go on to a basic talk by Dr. Garewal, in which he's going to talk about as to why he preferred SMILE as his option. And then I think the three of them, we can take questions together on them. Dr. Garewal, can you, Dr. Namrata, can you just introduce
Dr. S.P.S. Garewal is very well known to each one of us. He's the founder and managing director of Garewal Eye Institute, Chandigarh, and his talk is Why I Prefer SMILE.
Thank you so much, Dr. Namrata, and thank you, Maipal, for giving me a chance to be here with the elite faculty. My talk is going to be very, very simple, and it is based on the myths that I have been hearing from people. And unfortunately, most of these myths are in favor of LASIK and they are against SMILE. So I would like to go ahead with why I prefer SMILE. And I would like to set one thing in the correct text before, and that is, I only do SMILE. So then the question comes, why SMILE? Now, SMILE is a flapless procedure, as has been mentioned. There is no risk of flap displacement. There is a cap and there is no flap. So the flap-related complications, both intraoperative and post-operative, are completely eliminated. And all of us who have been doing LASIK and are doing LASIK now know that the complications do occur in the best of the hands. So since there is no flap, the corneal biomechanics are probably better maintained, and there is no risk of flap displacement or flap stria due to immediate or delayed post-operative mechanical insult to the cornea, which may be simply from rubbing the eyes inadvertently. In LASIK, because of the flap, there is a long list of complications that can occur. We have all encountered flap buttonholing, incomplete irregular flaps, corneal perforation, vertical gas breakthrough if you're doing the femto, flap stria, dislocation, DLK, and then interface debris may get trapped under the flap. With SMILE, since there is no flap, the flap-related intraoperative or postoperative complications are completely eliminated, which I personally feel is a huge advantage, and it avoids the sleepless nights before and after the surgery for the surgeon. The second part I would like to touch is on the exposure of the bed. Since we are making a flap, the bed is exposed in LASIK, and the duration for which the excimer laser fires depends on the refractive error. We all know greater the myopia, the longer is the duration for which the laser is fired. Since a flap is not raised, there is no drying of the stroma or change in the corneal thickness during the firing of the VisuMax laser, and you get more predictable results in the higher numbers. This is just a rough calculation to show how much time it takes. If you're doing LASIK, it may take about 13 seconds to make the flap, and for correction average, it may be about 9 seconds per diopter, and for one diopter, it will be about 22 seconds. And for a correction of 10 diopters, it will be approximately 103 seconds. Whereas in SMILE, it is approximately 24 seconds, may vary from 22 to 26 seconds, depending upon your total lenticle size that you are keeping. And whether it is 1 diopter or 10 diopter, the total time for which the laser fires is 24 seconds. It is not that it saves surgeon's time, but it is much less energy delivered into the cornea for higher numbers. And that is what probably is very, very significant from the points which have been very well highlighted by both my previous speakers. So your energy delivered in SMILE onto the cornea is significantly less than what you have in LASIK, and it does have its implications on the final results, as has been shown in the previous two talks. The next is the exposed stroma. As the laser fires, and between the lifting and the flap and you're getting onto doing the laser, there is a time gap. Now the corneal thickness decreases from the time the flap is lifted to the last laser shot due to drying up of the exposed surface. As the surface dries up, the corneal thickness reduces. As the corneal thickness reduces, the amount of the tissue which is evaporated by each pulse increases relatively. So as the cornea becomes thinner, the relative corneal tissue removed becomes more and more with every pulse. And it is very difficult to control the perfect timing from lifting the flap to finishing the procedure. And especially those cases where you have a flap and you have a little bit of bleeding and you spend time in clearing up the blood from the edge. In those cases, again, you are exposing the stroma to much longer duration, and then the results become a little unpredictable. In SMILE, there is no change in the corneal thickness during SMILE as stroma is not exposed to the atmosphere. This is the commonest question asked that, oh, I don't want to go in for the SMILE machine because doesn't have a tracking system. I'll prefer a LASIK because the tracking is there and tracking is required in refractive procedure. But the fact is that in LASIK, there is a distance of between 10 to 14 inches between the laser aperture and the cornea. It is essential and mandatory to track the eye movements, including the saccadic movements, so that the relative position of the laser shots remains constant. So tracking is required. In SMILE, the cornea is touching the quartz plate of the appinator and held by gentle suction, which completely eliminates any possibility of ocular movements. This is the best possible tracking system where the delivery and the receiver system becomes as one point. So there is no need of any kind of a tracking in the SMILE procedure. The other is the stability of the wavelength. We all know the wavelength, it's an ultraviolet wavelength in LASIK, whereas it is infrared light. So itself, these two wavelengths, the stability of these two wavelengths is a lot different. And lower wavelengths are not stable. They travel through the air before reaching the cornea and get affected by environmental factors like movement of the staff. And when I was doing LASIK, we had very strict instruction that when I say start, the staff will not move at all till the laser firing is complete, because even the movement of the staff creates currents which can affect the delivery of the variation in the power of the laser being delivered to the cornea. Same is the AC vent. If somebody changes the AC vent towards the patient's eye, it can lead to problem. Perfumes can lead to problems. Hand sanitizer sterilium is again important, and long time back, we had a very bad experience. I think we were starting with NABH accreditation. They said the sanitizer required. We used hand sanitizer on one day, and on those cases, we had very, very unpredictable results. So the amount of the protocol that you have to maintain for this is, and still you cannot control it completely. Whereas in SMILE, it's a stable wavelength. Besides that, there is no effect of environmental factors as no air is present while the laser performs the task. So it is a much more stable wavelength and accurately delivered onto the cornea. In LASIK, we have flying spot or broader beam, and these are circular spots. And as the firing goes, you can see the differences in the uniformity of the pattern, the way it is onto the cornea. This is the simulation. Even if after repeated firing onto the same area, the uniformity is not there. Here it is a spreading spot of air, and as the procedure goes on, you get a uniform dissection of the field, and therefore the ablation pattern remains much smoother than you have in LASIK. And we all know that in LASIK we have the plume suction. The very fact that the need of the suction is there because the plumes interfere with the energy of the subsequent beams. So these plumes have to be sucked up, and if somehow the filters are not okay and it is not properly positioned, it can affect your final ablation. As far as SMILE is concerned, there's no burning of the tissue, there are no plumes, so the plume-related issues are not there. Post-SMILE ectasia, the reported literature incidence of ectasia after SMILE is very rare, although there are sporadic cases now coming up about ectasia after SMILE, and many of them had some pre-op issues and case selection issues. Biomechanical strength, in LASIK, the flap does not add to the strength. In SMILE, it is better strength and it can withstand trauma better, and it is preferred for active sports. Now, this is one point which is important, that is the transition zone. As we know that as the laser spot is fired towards the periphery of the cornea, instead of being a circular spot, it becomes the oval spot. And the power decreases by a square root in these areas. So if the same energy is delivered over a larger surface area, its power comes down by square root. And the ablated thickness is also reduced by the square root. So the control of uniformity of ablation between the central of the cornea and the periphery of the cornea is very difficult to maintain. That is why we have a transition zone. Actually, the right word for transition zone should have been a non-optical zone. And that is why the issue of the night vision is there and glare at night is there. And that is why we have to have a wider area for ablation. In SMILE, there is nothing like a transition zone. Another myth which always comes when people talk about the LASIK and SMILE, that in SMILE you have to keep 10 to 15 or 20 micron extra tissue. So there is more tissue loss in SMILE than in LASIK, which I feel is not true, because the actual parameter that needs to be compared is the volume of the tissue that we are removing or we are sacrificing. And we look at the overall diameter in LASIK is much more than the diameter of the lenticule. So even for the same power, even if we are adding another 15 micron to the SMILE, the total volume of the tissue which is sacrificed is much less. And as far as the pupil size is concerned, it is not that significant because of the transition zone. People with a little bigger pupil also do not complain of the issues at night vision and glare, which was more common in LASIK cases. So corneal sensation, this I would not go into detail because I think this subject has been very thoroughly thrashed by Dr. Jodh, and he has given a fantastic scientific presentation in favor of it. And I think it's the first study showing that even at 5 years, there are different, which is a very, very big important point in favor of SMILE. So, and this is again showing the effect on the nerve. This part has already been discussed and already explained. Clinically, what I find is that those patients where we do SMILE now, the patients coming back and reporting of dry eyes is practically negligible. And if a patient with SMILE comes and says that he has a little dryness, my first question is, how long you have been using contact lens? So that is what shows that in those cases who have been using contact lens for longer hours and longer time before SMILE may experience dry eyes, but otherwise after SMILE, the incidence of dry eye is very less. So I'll skip it because it has been already. Now the contrast sensitivity is also better in SMILE as compared to LASIK. And this is that significantly much less halos and glares are there in SMILE than in LASIK. Now, this is one very significant difference in the current context with the youngsters who are going in this procedure want to get back to their work and active life, normal life very, very quickly. And that is where SMILE scores over LASIK by a huge margin. Since there is no flap, there is no risk of any complications. So there is no need for any restrictions. And after the next day's examination, patient can go back to the normal routine. With LASIK, it was a routine that after we have done, we'll keep the patient for 2 hours and then examine on the slit lamp, look at the flap, position of the flap, any sprayer, if need, take back to the OT. Now with SMILE, the moment the procedure is given, the patient is free to go home, which makes a huge difference. The epithelial growth is again a major difference of the reduction in complication between LASIK and SMILE. In SMILE, since the incision is very small, incidence of epithelial ingrowth is not there. However, there is a possibility of epithelial implantation that we can take. And if you look at this video, I have just removed the lenticle, but if I see this patella, you can see there is a small piece of epithelium which is sticking to it. And you have put paracrine, epithelium is a little loose. So when you take the instrument inside, you have to be really sure that you're not carrying any epithelium with you and implanting inside. Otherwise, the risk of epithelial ingrowth is taken care of. This is the study which has just come out, and this is from US Army, and the conclusion is that the first year after SMILE treatment in a US military center demonstrate early postoperative outcomes superior to PRK. SMILE seemed more predictable compared with LASIK, and that is what Professor Jodh had also mentioned. And the technology, definitely, it's a different technology, and as Dr. Mahipal said, this is the way to go. And when the other manufacturers also come out with the machine, I expect it to be the normal standard for doing the refractive procedures. Thank you so much.
Thank you so much, sir. I think this was one of the most illustrative and one of the simplest presentations comparing LASIK versus SMILE. So I think we can take the questions now from the first three presentations that arise.
Yeah, Dr. Ramamurthy, from starting with you as a panelist, I think you have wide experience with everything. You have the LASIK, also the SMILE. So how is it tilting toward A? And I'd also wish to ask Dr. Jodh and Rohit that the studies that they have shown, how important are they as regards the clinical outcomes? Does it really matter to the patient to that extent? Have you done contralateral eye studies, etc.? So Dr. Ram, first you, and then Dr. Ram.
Yeah, thank you, Mahipal. I mean, yes, we have 4 centers where we do refractive surgery. One of them only we have SMILE, and essentially what we find is that about 70 to 75% of the patients coming there, which is our principal center, we do SMILE largely. I have a question for Dr. Jodh. Excellent presentation, and maybe the first time it has been shown for a control follow-up over a period of 5 years. But what was surprising to me also was that you showed that as far as the clinical features was concerned, whether it's ocular surface index score or disease score or Schirmer's or dryness, there was no difference between the patients. And our general concept was what Dr. Grewal was saying, that at least in the initial period, 3 to 6 months, these patients are much better off. There's corneal sensation is better preserved with SMILE, and the dryness they experience is also much less. But you said otherwise. So it's great to know that the nerves are better preserved in as far as the spinal procedure is concerned. But how does it translate to a benefit as for the patient?
So Ram, hi. So we were looking at long-term studies. So most of the studies that have been published have only looked at 6 months. So I completely agree with Dr. Grewal with respect to early postoperative time period. There's a significant advantage, as I showed, with respect to nerve clinical symptoms on OSDI score. So that's I think nobody's going to argue with that. The question is obviously whether you get that benefit and you can maintain it long term. I have to say, from the RCT patients, these were all patients with good ocular surface before we recruited them into the trial. Okay, so these are pre-selected good patients. They all have good ocular surface. These are not patients that would have like maybe high dendritic ulcers or issues with contact lens wear or things like this beforehand. So these were pre-selected, and because we didn't want to bias the results of the study itself when we did this back in 2012, 2013. The point about the clinical symptoms and stuff that you see about 1 or 2 years out, it just shows you, it depends on how far you really want to push your clinical examination. If you start doing sequential like imaging, like BSTOF or something, where you're basically imaging ocular surface scans and looking at tear film breakup over like every 1 second, then I think you're going to be able to start to tweeze out some of the issues between the nerve and basically the ocular surface function. But generally, I think our ocular surface assessment, even the parameters that I basically showed you there, including OSDI, I think are generally quite poor to pick up these subtle kind of changes. And the point was is that even at 5 years, your LASIK eyes do not catch up. So if you have a patient that has a borderline situation where you have borderline dry eye, contact lens wearers, maybe those things, of course, you want to protect the ocular surface as best as you can. And that's why SMILE will give you that better assurance, not just in the short term, but also basically in the long term.
So I have a question for you. You compared SMILE versus LASIK, and most studies would do so. But what about, of course, in the refractive errors where it is possible to do? What about comparing a flapless procedure with a flap procedure or with a cap procedure? Comparing PRK with SMILE, what do you think? You think how would the results be different in terms of the corneal nerves?
I mean, the nerve regeneration with PRK is slightly different because, I mean, again, you get more inflammation initially because you've got the epithelium being denuded, and so you've got the epithelial exposure. So you've got a lot of basically cytokines and inflammatory markers going into basically the stroma in that early period. But then, as I showed in that diagram, the PRK eyes do normally basically pick up faster compared to basically the LASIK eyes, because essentially you're not basically going down so deep. My differentiation clinically on my patients, when I differentiate between surface procedure or SMILE, is not done purely on the nerves. I do it mainly on biomechanics. So I basically decide whether I'm going to basically do surface ablation or SMILE from a biomechanical standpoint, not an ocular surface, because I think that the ocular surface homeostasis is maintained quite well in SMILE. And I think that's probably also quite maintained quite well in PRK as well. You have to be careful a little bit in PRK, because I do think that they do get more inflammation in that early time period. But I mean, they're wearing contact lens normally for that sign, for that first couple of days anyway. But my decision between those two procedures is based on biomechanics. It's not based on ocular surface modalities.
And what is your percentage of SMILE?
I do a lot. I mean, I do mainly SMILE out of my cases. I mean, I think similar to what Dr. Grewal will basically showed on the thing, a lot of our patients that come in, I mean, I basically put it to them, anyone who has basically moderate to high degrees of myopia, I do SMILE as first choice. So that's normally about -5 or -450 and above. The ones that are lower than that, I basically, it depends on their hobbies. A lot of people are doing sports. They want to get back to basically gym stuff, or they're doing contact sports. If they're doing doing contact sports, then I will basically, I'll do SMILE as first choice because I'm going to avoid the flap related complications. If not, then I'll basically do LASIK on them. So most of my LASIK cases end up being in that lower range of lower degrees of myopia. I mean, in the trial that I showed, of course, it was different because that was a randomized controlled trial. But in clinical practice now, that's normally how I do the split.
Any more questions anybody would want to ask from the first three talks?
No, I would like to know from all three of them, are they convinced about the biomechanical superiority of SMILE? I mean, that's one question that I constantly have, in the sense that mathematical models by Dan Reinstein and then this finite clinical models have shown that there is some superiority. But as far as clinical studies are concerned, none of them have really shown that SMILE is superior to a femtosecond LASIK procedure. And what Joe just now said about his selecting patients based on that, I would like to believe that and like to do that, but I feel there is not enough clinical evidence to show that up.
I mean, Rohit's done obviously work on this area as well, but I would just say that I think it's stronger than doing LASIK, but I personally don't think it's stronger than doing PRK. We had a paper recently looking at 3-year follow-up of patients who actually came for LASIK, and then we used some formulas to work out what their risk score was, and actually a lot of those patients actually underwent SMILE and surface ablation. And I decide really on the fact that I'm less inclined to do LASIK on these patients in these moderate to high degree myopia groups, and I think it's related to the incision. Doing a smaller incision, 2.1 millimeter incision, compared to doing a LASIK flap. I feel much more comfortable to do that in SMILE. And most of these patients that we followed up for 3 years had PTA scores well above 40. And if they'd had LASIK, there would have been about 7 to 8% chance of them they would have got ectasia. And none of them got ectasia in the 3-year follow-up.
Rohit, how about you? What would be your basis of decision? Would be possibly the same for a surface ablation vis-a-vis a flap or a cap procedure?
Absolutely. I mean, only thing I would like to add here is when you are doing any of these procedures, especially even in SMILE, if you are, this is what I discussed with Jode last meeting, that even if you're doing a smile on an eye which has got a very bad ocular surface, if you're cutting very close flap, which is closer to your subbasal nerve plexus, you'll have the same effect as you would do with LASIK. So in an ocular surface patient, you have to, the cap has to be thicker, and because you, to preserve those nerves, because ultimately the whole talk, what I did today was, the nerves are not only responsible for your tears or sensation, it has a huge impact on how the epithelium remodels. And the way epithelium remodels has a huge impact on the quality of vision and the residual refractive error or even the regression.
So there's
Amrita,
a
can I ask? Okay,
yeah,
sorry,
please. No, continue. Continue.
Okay, there's a question which I thought, since all three are so experienced on smile, and I've been doing a lot of smile myself, but there's a dilemma always that when you're I make a cap of around 120, and if I'm running into a residual bed of say 300 or 290, and if you are kind of running short of tissue and you don't want to leave smaller than 290, would you rather leave that tissue on the cap or on the bed? Like if you have 10 to 15 microns, would you rather have a thicker cap? I mean, would you sacrifice that 120 to a 110 or 100? Or would you sacrifice the 290 for a 280 or 270 and leave behind a 120 cap? I hope I'm clear on that.
I'll leave more at the bed.
Because the argument is often that the anterior 1/3 of the stroma contributes most to the strength. So, it's always this dilemma that if that is the strongest, then
I agree with you absolutely, but this is not for every case. This is a special situation. In that situation, by leaving more at bed, you are still safer doing smile than it would have been LASIK. In LASIK, two points, like one is that in LASIK, you are leaving less normal rim of the cornea in the periphery because you are going 9.5 millimeter. In smile, you are usually 7.5 millimeters. You are leaving a very wide, normal, intact rim in the periphery, which adds to the strength of the cornea. So the strength of the cornea based on this will be better in smile than it will be in LASIK. Second is that your anterior 110, even if you're leaving 110, 115, your anterior rim is intact throughout. So that again goes in favor of smile. And the third point, which Dr. Ramamurthy asked, that which will be better, why, which is stronger? I don't think we have any excellent tool to tell us the finer differences in the biocompatibility. And a yardstick to measure will be the incidence of ectasia between the two conditions. And we all know that the ectasia is less in smile. So that answers that question, that which is leaving a stronger cornea behind.
Okay, so this question is
Can I ask a question, Amrita, please?
Yeah, Rupal, sure.
Yeah, the question is to Dr. Rohit. Rohit, I just wanted to know, when you make a flap, generally I think everybody makes a thin flap with a femtosecond laser, or with even microkeratome, we are trying to make thinner and thinner. Would that not affect the nerve plexus much more? Because the area also, as Dr. Grewal already pointed out, is much larger. So comparatively, even if you make a thin cap,
once you cut all the connection, there are so many other connections, not only the nerve bundles, the laser, everything changes the hemodynamics of the nerves. So basically, the whole presentation, both me and Jode's presentation, is all about preserving nerves is not just dry eye. Preserving nerves is a complete ocular surface and ocular health, from epithelium, tear film to everything. So many times we look at smile versus LASIK and look at only the dry eye component of it, and that's what Dr. Ramamurthy said. Sir said that we did not see any difference in your T-bud Shermers and all that. We will not see it, but you will see a lot in how it heals over time. You'll see a lot in how the epithelium heals over time. You'll see a lot in the quality of tear film optically over time. So to answer your question, thinner or thicker flap doesn't really make a huge difference. I think there are papers which are done. And so as long as you can bypass the nerves, it's better. Even in smile, in a dry eye patient, if you do take a very thinner cap, you will end up having the same issue of dry eye like you have it with LASIK. So This is the question I asked Dr. Jod last time, that in a dry eye patient or a contact lens intolerant patient, going deeper, does it make a difference? Dr. Jod, would you to answer this question?
Yeah. So last time we showed a paper that we published recently in IOVS, and that's exactly what we did basically. So we worked out where the nerve density was in a three-dimensional structure, a lenticule, with respect to refractive error. And what Rohit said is exactly correct. If you go more superficial, you're gonna basically take the nerve plexus. So in a dry eye patient, you're actually better off going deeper. So to answer Gaurav's question, my point would be that I would assess whether it was a dry eye patient to decide whether I leave it more in the cap or basically go deeper. If it's a low degree of myopia, I would go deeper because I know you're basically biomechanically going to be better at the top. I don't really concerned about going to basically 280 at the bottom because I know the eye is going to be stronger and my ocular surface is going to be better. So I would look at those components more to really make that judgment call whether to go more superficial or basically more deeper.
So, Jod, if you are doing even say a LASIK, either with microkeratome or with femto, is it better to go deeper if you have enough thickness and a low myopia to treat? So create a thicker flap as compared to a thinner one to preserve the nerve?
No, because the problem with LASIK you get the issue with is that there's two problems. So one, you have the nerve issue, but the second issue is you have the biomechanics. So you're sacrificing the biomechanics strength by basically going deeper in the cornea. Of course, if you go deeper, you will basically preserve plexus. You preserve the subbasal plexus, but you're cutting the nerves in the periphery. You see, so it's like having a tree trunk, and what you're doing is you're taking at the main branch of the tree trunk. So you've got the edges of the tree trunks still there, but you pulled away the main branches and stuff. So your nerves are going to basically degenerate. So it doesn't make point of basically going deeper. The other issue with LASIK flaps, especially with microkeratome, the flap dimensions are much larger than they are with the femtosecond laser. With femtosecond laser flaps, generally, basically, you have square edges. And even when we did an RCT about maybe 9 years ago now, where we compared LASIK flaps created with the VisuMax versus laser flap compared with the Intralase. And it was interesting in the fact that the nerve regeneration, the tear film, was superior in the VisuMax eyes compared to the Intralase eyes. Now, there's only a difference of 0.5 millimeter between the flap sizes. And can you imagine between a microkeratome flap and a LASIK and a femtosecond laser flap, there's a much bigger difference.
The last thing, if I just make one comment and then give it to ma'am, is when you're doing in your LASIK, when your flap is not aligned properly, you get even a little bit aligned issues. You get those scarring at the periphery. The scar actually prevents your the nerves to regenerate. The scarring never makes the nerves to regenerate. So that all this is avoided in SMILE, because you don't have a flap.
Okay, so I think that was a great discussion, and now I would request the next talk. The next talk is by Professor J.S. Chityal, who is the head of the Cornea, Cataract and Refractive Surgery Services at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. And he is going to be talking to us about simplifying cap lenticule dissection to improve outcomes. He's written a great book on SMILE, which was published just a few months ago, sir.
Yeah, thank you, Namrata. I think we had such a nice discussion on outcomes of SMILE surgery, right, from a clinical outcome to a molecular level, and that justifies people shifting to SMILE. And I know that laser application is better than a mechanical or a microkeratome treatment for a cornea. But one of the important thing is surgically things should be simple so that we don't create much problem for these cases. So if you see these SMILE surgeries, that does have its own issues if you begin with as a learner in these cases. So we know that there are 3 simple steps for SMILE surgery. First would be a appropriate proper docking of applanator to the cornea. And second is a laser application to create the refractive stromal lenticule, intrastromal lenticule for these cases. And the most important thing subsequently is the manual lenticule dissection and extraction of the refractive lenticule which we have created. So there are 5 or 6 steps in lenticular extraction which are important. The first one is identifying, then opening the cap side cut. I think this is one of the most important steps to assess how deep, how superficial you are to create the lenticule edge. That is by doing an anterior and posterior channel dissection through that will create the lenticule edge for your subsequent dissection for anterior plane, then subsequently going deeper for a lenticule bed dissection. So these 4 important steps are there to get you to a lenticule which could be extracted safely by various techniques. And after you extract, you need to inspect the lenticule for its completeness, especially in a difficult cases. So these are very simple steps, which is not going to make huge difference in terms of a timing of a surgery in these cases, as nicely described by Dr. Garewal, comparing the LASIK and SMILE in these cases. Let me show these small clips of video to show how effectively we can do. The first is the application of femtosecond laser to create this intrastomal lenticule. You can see that we have created the side cut now. Now we'll be creating the cap, which is coming from center to periphery. And entire procedure takes 22 to 28 seconds, depending on laser energy in these cases. So this is what I was saying. So you have 2 clear-cut margins. One is the cap, one is the lenticule side. And this is the incision, which is important to be highlighted. So what I do normally, I'll put a gentle massage on the incision size to delineate both the rings clearly. Then go gently from left to right. Make sure you are properly into the incision. Then I do an anterior pocket. So this is a 2 millimeter incision. Then go towards my right hand side to create a posterior pocket. So I have both the pockets now. Then take a dissector, which normally you can see this. I have clearly delineated my posterior edge. So this is what I have to clarifying the lenticular edge, which is so important. Go anteriorly towards the left hand side, avoiding the edge we have created towards the right hand side. Make sure you have a smoother dissection into the pupillary area. This is very important. And you can see how if this is a left eye. Many people do have a little difficult left eye towards the right hand side. Now I go posteriorly. So see how effectively I'm doing. I'll delineate the edge here. One, I release here. Leave little attachment to the side so that you have a fulcrum to dissect completely. If you dissect out from one side, the entire flap or lenticule goes to one side and becomes very difficult to dissect out. So I have a complete dissection now. You can just roll in, make a little bit of gola and take it out. You don't require a forceps nowadays to remove this lenticule. So you saw that steps are very simple. It does depend on how effectively laser have been delivered and how easily you can make the lenticule edge visible by anterior and posterior dissection. That is the most important step in a dissection of lenticule. This is our review article on lenticule extraction techniques in clinical ophthalmology, in which there are various description of various techniques to dissect and remove the lenticule from the bed. So there's a Chung swing technique where he does a posterior plane dissection first, then subsequently comes to anteriorly and dissect out. So this is a simple technique where there's always a risk of lenticular tear, side cut extension, and retention of a lenticule also is possible in this technique. Then people do a continuous culvinar lenticular rexus technique also, where they do anterior plane dissection first, then hold the lenticule from the edge and do a rexus type of technique to remove the entire lenticule without doing the posterior dissection in these cases. So this has a potential risk of a lenticule tear, partial extraction of a lenticule. Sometimes extension of a side cut is very, very common in this technique. Lenticular slices, where again they do a little bit of a peeling off from the incision side, then hold the entire edge and do a circumferential manipulation to remove the entire lenticule in these cases. Then people do a lenticule irrigation, where they use BSS injected through a small incision to identify the anterior posterior plane, then remove the lenticule by forceps. Or people do a anterior posterior dissection, use hydro expression without using the forceps in these cases. Then push-up technique, where they use an incision like a Y-shaped incision, which we use in a cataract surgery sometimes, to push the edge and make the edge visible. Then subsequently you can extend the entire lenticule in these cases. We have also used intraoptical or coherent tomography, IOCT microscope to delineate the plane in difficult cases and subsequently dissect appropriately in these cases. Sequential segmental dissection can also be done from the anterior plane, then removing them nicely in these cases. So as I said, all these techniques are there, but you have to get used to one technique which is simple and effective for your cases. Learning curve is always there. You do have a difficulties which will be covered subsequently by another speaker. Suction loss to a cap side cut tear in these cases do happen. But as you graduate to more cases, your complications, difficulties go down significantly from a 16% to 2% in a 50 first cases of yours. So let me just tell you what all things can happen in lenticular dissection. Just simplifying in this diagram here, you have done an appropriately correctly anterior dissection first, but you find difficulty in going posteriorly. Or you have entered directly posteriorly in these cases, then you struggle to find another posterior layer. In that process, you can damage the stoma in these cases. So once you have this difficulty of identification, that's going to give you more challenges. You can have retained lenticule, delayed visual recovery because of a lot of stomal manipulations, cap tear, side cut tear extension, posterior stomal damage, epithelial defect, especially towards the cap side cut area, and can induce irregular astigmatism sometimes. The incidence is quite less. You have various ways to look into that area. Anti-segment OCT or Sinskey hook or various other instruments can give you a delineation in these cases. OCT gives you a nice picture. Like one of this case, I had difficulty. This is one of the first case of mine where I had cap lenticular adhesion. So I was going posteriorly to damage the posterior stoma while it was attached to the cap. So anti-segment OCT in difficult situation can be really helpful in these cases. Just one small video here where I did a correct dissection, right, from a right-hand side to left side to open the incision area, then do an anterior dissection, then go posteriorly to do a posterior dissection towards the right-hand side, which is a normal feature in these cases. So this is what I'm trying to do, a posterior dissection. Subsequently, I have done an anterior dissection in this particular case. But after anterior dissection, I've done completely. I was struggling to see the posterior disc. You can see here, I can't go posteriorly. So what exactly went wrong to begin with, that you have to analyze. You must see your videos subsequently also, and you can rectify your steps in these cases. So if you see here, I was initially dissecting, I had gone posteriorly. You can see this is edge which is delineated. So this is a clear indication I had gone posteriorly. In such cases, you can just enlarge the dissection towards the cap side by a reverse side of a dissector. This will make the edge more visible, come towards the incision area so that you can insert or you can put your dissector over the lenticule and gives you a nice dissection anterior to the. So once you identify this correctly, you can dissect out very effectively in these cases. So it is the edge identification which is so important for these cases. So this is one more patient. I had a similar difficulty dissecting in this case posteriorly because I had gone posteriorly directly. So what I am doing here, once you have little bit of fluid here, so it's very difficult. So I have just done anterior dissection. Then I'll show you how I've reached the posterior dissection in this particular case here. So I'm again struggling to see a posterior dissection in this particular case, but just observe the area here. So I already have an edge. So I'll just go anterior to that and push the entire lenticule towards the central area. Then I have a flap. I'll go anteriorly, and now dissection can be simplifiedly, can be delineated, and lenticule can be selected by rotation like a rexis. That attach can be taken out. So the main crux here is to do an appropriate clarity of a dissection area must. So if you have a good dissection, smooth dissection, this is what a first day picture of a SMILE patient is. This is the OCT of the same patient here. So meniscus sign, which I described, is one of the very, very important aspects for the edge delineation for an appropriate dissection by your patient. So once you see this line over the dissector, you are in the posterior plane. And if you don't see the line here, you are in the anterior plane. If you understand this, you'll never have difficulty in these cases. This is the algorithm we have made depending on the type of dissection you make. And once you have a difficulty of getting to a second plane, so either you go push the lenticule towards the center side, that will give you a idea it is anteriorly attached or posteriorly attached. Accordingly, you can manage subsequently these cases. To summarize, the surgery is simple in a SMILE cases. You have to understand various techniques. There's a little learning curve compared to LASIK patients. And we know that lenticle dissection extraction is the most challenging step intraoperatively for these cases. Multiple complications can happen in a difficult situations. Training, seeing your videos assisted by an experienced surgeon is very important in these cases. And classically, if you can delineate the edge appropriately, like a meniscus sign, things become very, very simple. And this is what I wanted to stress. Always look for a meniscus sign that tells you you're posteriorly all the time. Thank you for your kind listening, and hope that the subsequent discussion will be appropriate and good for everybody. Thank you again.
Thank you, sir, for that, for actually simplifying the cap lenticule dissection, because sometimes it can get very tricky and can get very difficult. And it was lucidly covered by videos as well as illustrations. And now I think I would request Dr. Gitansha Sachdev to give her talk. She's the youngest, I think, amongst all of us, and consultant at Cataract and Refractive Services Eye Foundation. And she is academically very accomplished and is a great innovator, has done, even at this young age, a lot of innovations. And she's going to be speaking about innovations in SMILE.
Thank you so very much, ma'am, for this very kind introduction. So I've been given a very interesting topic on innovations in SMILE. I have no financial interest. I'm going to be dealing with this under the following broad subcategories. So let's begin with how to improve dissection techniques. Now, getting the lenticule edge right with subsequent anterior and posterior plane delineation is perhaps the most important step in SMILE. The meniscus sign, as Professor Titial has already elegantly alluded to, is simply a sign wherein you can see that there is an outer ring for the cap cut and an inner ring for the lenticule side cut. So in the lower right-hand side, you can see that when the surgeon pushes the lenticule forward, it results in a meniscus-shaped gap between the lenticle edge and the diameter of the remaining lenticular cut. Other signs that are described are the white ring sign, wherein the position of the white reflex relative to the instrument lets the surgeon know whether they are anterior or posterior. However, this warrants a uniform, good OBL throughout and also requires an additional oblique illumination in cases of dark irises. So we have described the SOP sign, wherein you can see that there will be a resistance between the dissected and the undissected halves of the anterior and the posterior plane, which does not allow the lateral movement of the spatula further. This can be seen at both the anterior and the posterior lenticular plane. Now, this is a contrarian surgical video wherein you will see the absence of a stop sign because the surgeon has gone on to do a posterior lenticular dissection in both attempts. So following opening of the side cut, this is the first attempt wherein the posterior lenticule has been delineated. And you can see subsequently, because we are in the same plane, there is absolutely no resistance to the lateral movement of the instrument. Now moving on to another controversy, which is addressing astigmatism in SMILE. We're all aware that there is a lack of an active cyclotorsion compensation, because of which a number of manual compensation techniques have been described. So what you see in the video is a triple centration, wherein the marks are placed well within the cornea as against limbal markings, and either 2 marks or 3 marks can be used. Now, a handful of studies have addressed this issue. The first showed significantly better results following cyclotorsion compensation in high astigmatism and cyclotorsion. However, one of the largest limitations of this study was that there was no control arm. It just compared with historical cohorts, and it applied a 10% overcorrection nomogram, where the historical cohorts had no nomogram applied. Subsequent studies showed no statistically significant difference. Another study by Chen et al. Showed better outcomes. However, the cyclotorsion that was studied was very low, with an average of about 2 degrees. So in order to overcome these limitations, we've done a contralateral study with patients with a high preoperative astigmatism and a cyclotorsion of more than 5 degrees. This is currently under review, and we have found no statistically significant difference in the visual outcomes. Now, one of the most important complications in the SMILE procedure is retained lenticules. If we have larger or more central remnants, it can result in irregular astigmatism, increased corneal aberrations with subsequent loss in corrected visual acuity. The use of an intraoperative ASOCT has been described. However, the lack of it being freely available and the cost are obviously potential limitations. Again, very thin lenticules may not be picked up easily with the ASOCT. The Circle software has also been described in a handful of cases where a conversion into a flap allows peeling off the retained fragments, but one obviously loses the biomechanical advantage that we had with SMILE in the initial place. So we have described the use of an intraoperative wash with diluted preservative-free triamcinolone. You can see that the crystals beautifully deposit at the edges of the lenticule and allow subsequent delineation. The advantages would be that it is cheap, it's freely available, works even with thin lenticules, and also in cases where you might have some corneal edema secondary to excessive manipulations from the primary procedure itself. So this was a case where we had a 1.5 diopter correction, and there was a central steepening because of retained lenticule. You can see that the ASOCT has failed to demonstrate any lenticule. The patient did very well following the triamcinolone technique and resolved with an unaided vision of 20/20. And this is an interesting thing that I'd like to discuss is the off-label use of the Circle software. Now we're all aware that the Circle software is essentially made to convert the initial cap into a flap, which is then raised and ablated to treat any undercorrection or regression. So I'd like to show the off-label use of the Circle software, for 2 cases of suction loss. This is a suction loss during the side cut during the SMILE procedure, wherein you can see that the superiorly encroaching conjunctiva has interfered with the femtosecond laser delivery and one does not have a side cut. We tried gaining access through a sharp-tipped instrument, but were unable to do so. So the only thing that I could have done at that juncture was to abort the procedure. We instead decided to use the Circle software and converted the cap into a flap. Now, the important caveat to remember here is to do the delineation posterior to the lenticule, as one should not enter the junction cut and create a false passage. This cap, the flap, along with the lenticule is now reflected. One can use a non-tooth forceps to stabilize the flap atraumatically and slowly go on to undermine the lenticule from the overlying flap. It is exceedingly important to spread the lenticule and make sure it has been removed in its entirety. You can see that there's a small sliver of tissue which was missing, which is subsequently removed, and the flap is reposited. Now, this is a rarer but another interesting case of a patient who was undergoing a femtosecond LASIK. So this is the first laser pass wherein we are making the flap, but there is a suction loss and we were unable to create the flap completely. As the femtosecond laser is exceedingly precise, you go on and read up the patient in the same sitting as the newly formed cavitation bubbles would percolate into the previously formed plane. So we've gone ahead and completed the flap cut, but again, because of certain movements, there is a suction loss and there is no formed side cut. So what could I do at this stage? I could either take a microkeratome and risk a biplanar flap. We could start with a femtosecond laser all over again and risk a potential suction loss, or do PRK at a later date. This essentially happened because I had run out of retreatment licenses and I could not make the side cut only. So what I did was I used the pattern A of the Circle software, which is only a vertical cut. The only difference was that I reduced the diameter by around 0.5 millimeters to compensate for any errors in subsequent centration. So you can see that we made 90-degree vertical side cut using the pattern A software of the Circle. This is then subsequently delineated from the underlying stroma as is done in a regular femtosecond LASIK. I'd also like to discuss the innovative uses of lenticule. So we've described the use of the lenticule obtained for SMILE for intraoperative stromal augmentation in thin corneas of keratoconus. This is an epi-off procedure. It begins with removing the epithelium with a blunt spatula. The lenticule is obtained from patients undergoing small incision lenticule extraction for a myopic correction. All the patients undergo a serology for both hepatitis and HIV. Now, the lenticule that is procured is thickest at the center and thinner peripherally. So the placement should be such that the center of the lenticule overlies the thinnest area of the cone, and an intraoperative stromal thickness of more than 400 microns is confirmed. Cross-linking, either accelerated or conventional, is done, and you can see that the lenticule, unlike a contact lens, remains firmly adherent to the underlying surface throughout the procedure. It is subsequently peeled off, the underlying surface is irrigated, and contact lens is placed. Now, having seen the safety and the efficacy of this procedure over a 5-year follow-up, we went on to combine it with the use of intracorneal ring segments in more aberrated eyes, wherein the best corrected spectacle visual acuity was poor. Other innovative uses that have been described is really for the use of the lenticule intrastromally, both for the correction of hyperopia and also for the correction of mild to moderate cases of keratoconus in conjunction with cross-linking. So I'd just like to say that SMILE is the future, and with a number of innovations, this technology is going to go places and it's going to be a lot of fun to be with. Thank you.
Thank you very much, Dr. Gidansha. Do we have any questions or comments, or we can take it after my talk?
If I might just add to what Jeevan so nicely spoke about, the extraction of the lenticule. I think I'd just like to emphasize a couple of points about what we do with the laser also. We got the machine about 5 years back, and at that time, we were using about 37, 38 as our power setting. And now gradually we have dropped it down to 30 or to 29. And that into 5 is the number in nanojoules. And again, the spot spacing also, we have made it 4.5 microns. Initially, it was 3.5 microns. Because of that, I think that he showed so beautifully all the steps in taking out the lenticule intact. But what you do with the laser is also extremely important. This 29 and 30 is obviously not for the panelists or for the speakers, but maybe some listeners who are new to the technology. It's not a golden number. I think each one has to slowly drop down the numbers and derive at what exactly suits their conditions, their machine best. Another thing is when I activate suction, it's at 80% meniscus that I activate suction. That I find that it gives me the right kind of hold. The chance of losing suction is less. At the same time, the chance of distortion of the cornea is also less. And the subsequent steps, what you do with for extracting the lenticule goes off quite well.
Dr. Rupal, you want to comment something on the energy optimization, the interplay of the energy, the spot spacing, etc., line spacing, spot spacing, etc. How important is it?
Thank you, Dr. Maipal. I think it is very important that you have the correct spot spacing as well as the energy parameters adjusted right in the beginning. And the application specialists of ZEISS are really hands-on on that, and they do help you to achieve that. More so, I think once you start using the parameters that they set, it's important that you yourself also look into it more carefully. Try to adjust this one step above and below, as Dr. Ramamurthy said, and see whether it makes and facilitates your lenticule removal as well as the first day post-op recovery, and that really helps. And that differs from laser to laser, from place to place. So don't just go by somebody else's settings and try to apply it to your laser. Dr. Gidansha, I would like to say that that was a really wonderful and innovative way of using the Circle software. I really liked your slide about the zeros, the circle and how it is applied in real life. I can only think of zeros that I had sometimes, hopefully following some number in front. But that was really innovative and nice way of using the Circle software. Only thing is, word of caution that you are spending some money on using the surgical software and doesn't come free like what you would have for a retreatment. So better preserve your licenses and not use it only to do a side cut as far as possible.
She doesn't worry about that.
She doesn't need to worry about that.
No, but I think that is something that we have been talking about, that the circle software is essentially used for retreatment. We don't charge patients for retreatment. The circle should be free to us. So that's without Vardhaman or anybody else.
Yes,
Vardhaman.
Thank you, sir.
Gaurav.
Yes,
Vardhaman, yes.
Yes, thank you, sir. I think I loved, of course, Professor Titial sir's talks and Gitansha's talk. Gitansha, congratulations, excellent innovations and great publications. So especially for Circle, so as Gitansha has shown, during the suction loss, she has wonderfully used it by creating a flap and then peeling off the lenticule. So there is a recent thing that we have published in which we had a similar situation. And what we did was that we increased the hinge width of the Circle software to that extent that the side cut became only 3 millimeters. So we tried to retain the flapless nature of Smile, and then we did the dissection like in Smile and removed the lenticule. So, and the second thing we are trying to publish now with LVP group together is that we have used Circle for epithelial isolated ingrowth in the visual axis. And we have used Circle to lift the flap and then scrape the epithelial ingrowth and put the flap back. And that has worked very well for us. But congratulations on your great innovations. Thank you again.
Gaurav, you want to say something?
Yes, I wanted to, in fact, pose a question to Dr. Titial. And fantastic talk, Gitansha. Really enjoyed your innovations. And sir, your videos were amazing. But there's a question which I'm actually putting up on behalf of some of the people who start out on Smile and they find it difficult to center. A common thing which I get asked is that when you're applanating and when you're kind of having the green fixation, some people find it very tough on whether they should be centering the fixation light. Should be in the middle of the pupil, or you let the patient look into the light and then center, and whether you can, get sometimes, the cornea, displaces the moment you have applanation, it kind of moves a little bit to one side. Should you then, kind of redock? What should you do? So, these are questions which sometimes I found it tough to answer. I thought the master will be able to answer it better.
No, actually, it is a pupil-centered treatment most often. And when the patient is seeing toward the green light, it's a actual fixation point. If that is centered, I think that's the best way. And Dr. Grewal nicely talked about, little bit of decentration in the pupil area may not make a huge difference to the ultimate outcome in a Smile patient. That's a very forgivingness nature of this particular technique. So most often it is the pupil center. Actually, when the patient is seeing the green light, that's the actual fixation of the versions. So just a central fixation. That's why if it is too much eccentric, I think you should redo it. So once you do this thing, infrared, what do you call that? You can put off and see, and if the pupil centration is correct in these cases. Normally, we can do very nicely, and Dr. Ramamurthy nicely pointed out, you have to go to around 80% of appellation before you apply the succession, and that decreases the the movement which can shift the fixation in these cases. So that's a very important point which has been highlighted.
Perfect. Thank you so much, sir. I think that kind of explains it really well.
Well,
Dr. Michael, with your kind permission, can I ask a quick question to Dr. Titial?
Sure.
Dr. Titial, wonderful videos. I just wanted to know, do you find any difference in the first day post-op recovery of vision, whether you use one type of technique or the other? So do you have a preference for one over the other out of all the different techniques of lenticular extraction you showed?
Actually, what I do a conventional technique of doing an anterior dissection first, then going to the lenticular base subsequently. But there are often chances where I have to do a posterior dissection first also. I think the smoothness of dissection makes a difference next day, patient's visual acuity wise. And I've seen especially what Gitansha talked about, if you have more OVL in these cases where it makes a dissection very difficult sometimes. Despite having a good dissection, these cases will have a little bit of a delayed recovery happening in these patients. But technique wise, I've not found difference if I go posteriorly first or if I go anteriorly first. It depends how difficult your dissection was. Otherwise, both have the same results next day post-op.
Thank you.
Mahibal sir, can I point out one thing over here that, sir has of course explained everything. There is a general misconception in people's minds because of, old data coming up that post-smile, your visual recovery is delayed and on first day post-op, you don't have a wow factor. I think it's just a learning curve over 6 months to 8 months. All of us will experience the same thing. We all get our first day one patients reading 6.6 or 6.5. Eyes are so clean, so much cleaner than our LASIK patients. So, I feel that smile, that small thing which probably came up in the beginning is not justifiably there. The wow factor is tremendous, better than LASIK and other procedures, in fact, for that matter.
Gaurav, I think you made a very nice point. That's why I think I asked the question about energy optimization. Even the FDA trials that were happening just recently, the point is that because in the trials you fix the energy levels, you fix the spot separation, you fix the line separation. So earlier, I would say that we were delivering much more energy, which Dr. Ramamurthy also pointed out. So you have to optimize the energy settings so that you don't have excessive OBL and you don't have cold areas. So if your cleavage is good, the separation is really very, very simple, and therefore the amount of manipulation that you do is much less, and the patients have 6.6 vision. So today until of course it's been rare that we are not getting 6.6 the next day or 6.5 the next day, because by the time you have done X number of cases, and it will depend from individual to individual, and I don't think it's more than 50 eyes or 650 to 100 eyes that you have, then you have optimized. So please understand, anybody who has purchased the machine should optimize the energy settings, and it should not be at the factory settings which are there. Each machine will have a little bit difference in its optimization. Each environmental condition may have a little bit in the optimization and how you separate out. So there is no question of having excessive inflammation nowadays. As earlier also, I think the speed of the laser was less, and that was also the reason where when even femtosecond laser came for the flap, there was supposed to be more inflammation and more reaction similar to a DLK or whatever. Once the energy optimization has been done, and just to tell you that we are also working on with another company, and the most important thing is to optimize the energy. And that is where the maximum input is going. So that is what I would wish to say, and Gaurav, you have pointed it out pretty well. So I'll just go on with my talk, and that is actually, I really, missed out on Dr. Titial's talk, so there may be a little bit of overlap, but I'll be talking about the complications as to what can go wrong with the smile procedure. And as was pointed out, conventional LASIK has moved on to blade-free LASIK, and I would say that though Dr. Garewal says that he does only smile, I would say that 90% of my patients are smile, and we don't do smile if there are very thin corneas where we can go on to surface ablation, or if there is a hyperopic patient, or there is a mixed astigmatism. But apart from that, I think, of course, there is a question of a person not being able to afford. At least in our hands, smile is the preferred technique, and we have all seen the various steps of smile. I think I'll just go through. Dr. Titial must have shown all this. There is no need for any excimer laser, and this is the normal procedure of smile, as you can see. So there are 4 passes to it. First is the posterior surface of the lenticule, which comes on. And as was told by Dr. Garewal, it's about 23 seconds to 24 seconds that you have. Then you have the side cut. This is the cut on the cap cut that is being happening. And you can see that this is a reasonably nice pattern where there isn't any significant amount of OBL. And then you can reduce the size to 2 millimeters. That is what the machine allows, but you can go lower than that. You can just open the side cut. And I always prefer to go on the anterior part first and then go to the posterior. And you can just go in with a blunt rod and separate out. And you can see that the separation is pretty easy. It just takes 1 or 2 firm steps on one direction, and similarly on the other direction that you have. And it's a very gentle thing, as Gaurav was pointing out. If you are really not manipulating much, as you can see, there is very little manipulation. The eyes will be pristine, clear the next day. And you can see this is the posterior area that we are going in, that is into the posterior part of the lenticule, and you can see there's a lift here where the lenticule is getting separated, and we can go in through with a forceps and just remove it out very well, and you can see how gently and exquisitely it can come out. Now, Dr. Gitansha has talked about the circle treatment, and Vardhaman also talked about it. But as things stand today, there is work that is going on where you can redo a smile on a smile. But as things stand today, either you do a surface ablation or you do what is a circle treatment. So the actual thing for which the circle treatment has been used, I will show you that. The innovations was talked about by Gitansha. So when you're doing at a circle, when you're doing a smile enhancement, you need a circle scan. And what you do is that this is the posterior part of the lenticule which was there. So we actually go and increase it from a cap to a flap. So that is what we do. And just let me show you what it is. It's a very simple thing. Because there is a plane that has already been created. And if you have the old data, you will want to go at the same setting, same bed thickness, and you can see that we are extending the cap to a flap, and you see it's like a donut shaped, and very nicely you can see that it has become a flap, and you can see that this is the area where the earlier lenticule was taken, and you can go ahead and do a surface ablation and put it back. Now, what is very, very important is that when you're looking at smile enhancements, they are much, much safer than if you are doing a LASIK redo. Because it has been clearly shown that if you relift a flap of LASIK, the chances of epithelial ingrowth, as you can see here, are much more as compared to a fresh cut. So whenever you're doing an enhancement of a smile, you are actually cutting a fresh flap. So as was seen with the circle scan, the flap is fresh, and therefore you do not get the incidence of the epithelial ingrowth which is there. Now let us look at the problems that can happen intraoperatively and postoperatively. So we'll be talking about all of them. So let us just look at the intraoperative. First of all, you can have interface debris. So what is very, very important for you is that if you have interface debris, like you can see that there is a lash here, and you are having an interface debris, you should redock, remove this debris, and then redock and recut. So you can see here what happens is that there is going to be a cold area because of the cilia which has inadvertently come, and you will have an uncut area. So the laser will not cut through this particular area. So you have to be very careful, and you have to separate it out. It becomes a little difficult. You can use this blunt rod, or you can have the duck-billed spatula which is sharp on the sides, which can also be used, and then you can go ahead and complete the procedure. But mind you that fine fibers or something may not matter, but a cilia like this definitely has to be removed. Now, let us look at suction loss. If you are having suction loss, the reason for suction loss is that a flap normally takes about 12-14 seconds. But if you are doing a smile procedure, you have the suction which is supposed to be there for about 23-24 seconds. Now, this is longer than otherwise. The second thing is to maintain the cornea. We are having a very soft, gentle suction on the cornea. So there could be a loss of contact between the glass interface and the cornea, or because of head movements, or of ocular factors like excess reflex tearing or poor fixation, etc. Now, when you are looking at the suction loss, it depends upon what stage you have suction loss, and basically depending upon that, the machine will take you what exactly you have to do. If you are first cut and it is less than 10% and there is a suction loss, you can go back and restart the entire procedure without any problem. If it is greater than 10%, then you will have to convert it into a flap. That means it has to be a femtosecond laser flap, which is, and in case it is later on that you have, then you can relock and you can recut, or you can have just the side cut which is required. So let me just show you the suction loss at various points. So this is the posterior lenticule that is being made. So you can see here that this is posterior, and suddenly the patient jerks. So we can do nothing but make this into a femtosecond flap, and you can see that we have made it into a flap, and we can complete the procedure on the same sitting as a femtosecond laser. That means a LASIK procedure and not a smile procedure. Now, if there is a suction loss at the time of doing an interior, you can see this is loss of suction at this particular point. So once you lose suction at this point, you can go back and dock, redock at the same point. And once you have redocked, the laser fire at exactly the same plane because you have not changed any settings. And you can see that the laser is firing, and then you have the side cut. And it will go ahead, and you can see once this is the burp sign, you go in, the OBL comes out, and the clarity of the patient improves. And then we can go ahead and do the dissection. So I'll just go fast forward. You can see that we have been able to do the dissection pretty well. There is really no problem in the inferior and the posterior separations that you have. So if you have a loss of suction at towards the end, all you have to do is just to redock. You can use the problem. And you can see that we are able to get a good outcome. Now, if you are looking at dissection difficulty, I just heard in the discussion with the Professor Titial, but here you can see that there is a lift on the edge. So we have gone into the posterior behind the lenticule. This is posterior to the lenticule, and once we try to search that as to now trying to go in the posterior, actually the posterior has already been separated. So what you have to do now is to find out whether there is a lenticule anterior or posterior that has been separated. So you have to just see. So you just visualize. So can you see that I found that there is an edge, and you can start separating it like a reverse capsular axis. And once you have found the plane, you can go in, as you can see that you can go into the plane and separate it out and take out the lenticule. So this is again something where it is just a question of visualization and trying to understand what is the anatomical planes that you have created and which plane you have entered, and you can see that we can remove the lenticule pretty well. Now, if there is, as Dr. Gitansha had shown, there could be cold areas and there could be fragmentation. So you can see that the lenticule has been fragmented here. You can use, in this particular case, I haven't used triamcinolone, but again, you can see you spread the lenticule, retain the lenticule, and you can see that there is an area which is missing. So if you actually even put fluid, you can see that this is the lenticule fragment which is there. You can go ahead and hold it and remove it. Post-operatively, OCT can also be done, but at that time, any dye can be used or a tricot can be used, which can be used for finding out if they're related. Be very careful. I normally do not use a straight forceps. I use a bent forceps, and if you lift your hand, you can have a side cut extension, and the side cut extension epithelial actually embedding of the epithelium, as Dr. Garewal has said, you normally don't get an ingrowth because this is an epithelium which is here. You can't see any streak which is taking it there. So it is not an ingrowth which is there. So you can go in and remove, but as Vardman said, a better idea today would be to do a circle scan. Once you have done a circle scan, you can actually lift it and remove the epithelium, but otherwise you can go ahead, wash it out, and maybe use mitomycin C at that particular point. Now, if you look at post-operative things, dry eye, as was said, is the least that you expect in a patient of SMILE. The patients rarely complained of dryness until, of course, they have long-term history of contact lens wear and had subminimal tear functions prior to the procedure. It is always better to optimize the surface before you go ahead and do a SMILE procedure also. We have reported a case of unilateral corneal ectasia. Now, in the post-op period, as Dr. Garewal was saying, there are now cases of ectasia that are happening. In this particular case, we have not been able to find anything wrong with the pre-op parameters, and in the case of unilateral corneal ectasia that has been managed with the intacs and with a slinking. Patient is stable in both the eyes. One eye only had a unilateral ectasia which is there. Now, this case has been reported out of Eye Foundation, and I wish to thank Gitansha for this. This is a unilateral sterile infiltrate which was seen following small incision lenticular excision. So you can get this kind of a picture that is there, which is sterile. Obviously, there is a problem that you have to differentiate it between an infective and a sterile, but this has been also reported as a case of LASIK in one of the webinars. I was listening to somebody, and this is the case of a sterile inflammation which is there, and it just responded with steroids, and you can see. So to sum up, I would say that there are basically the challenges that you can get with SMILE. You can have DL as this thing which is very rare. You could have an infection that has been reported post-smile. But I think overall the challenges with smile are the initial learning curve. I think there needs to be a little bit of more surgical acumen that is required for smile than that is required for a flap. But I think most of us are able to get through with the first 50 cases. The challenges with smile are rare. I think the machine is very forgiving and these are manageable and there is no loss of best corrected visual acuity. And what is important is that you need to have an appropriate knowledge of how to manage where you lose suction, how do you go ahead, what is wrong, how is the dissection planes, etc. That is something very, very important. And now you have lots of these videos that are available on YouTube and the teaching that is there. I think the things have improved significantly and learning smile is no longer a challenge. There are a lot of places where you can get the smile induction courses that can be done. So overall, as things stand today, with us, we have about 5 machines of smile across center per site, and this is the procedure of choice. Wherever we can afford, we will prefer to have a smile unit which is there. The limitations with smile are that at present it is not approved for hyperopia, though there are several studies that are going on. There is no automated cyclotorsion compensation, which I think is something that should come along, and there is no available re-smile for enhancement. So you have to go ahead with either a surface ablation or a circle scan which is there. So all in all, that is a brief summary of the type of complications that you can have with smile treatment. And I would say that the patients with smile are happier, they are much better, you get great outcomes, and the stability of the outcomes is much more. I think the incidence of regression and retreatment is far lower that we had than when we were doing the laser vision correction through a flap and an excimer laser. So this is a preferred technique for us today, and I've been able to show you the complications that can happen with smile. Thank you very much for your kind attention.
Thank you, sir, again for covering almost all the complications of smile. I think between the 3 presentations, we've covered everything possible about smile. Any questions before we go to the next talk?
Dr. Namrata, can I just add one little thing?
Please.
Dr. Maipal really nicely covered. What we also make use of is the slit lamp attachment, which is there on the Visumex to find retained lenticule if you are suspecting one. And that also helps on table to tell you whether there is a retained lenticule, and you can also remove it with that slit lamp attachment present, which is very useful if you can make use of it.
I think that's a good point that you have made, that there is a slit lamp attachment which is there in the Visumex by which you can at the end of the procedure do a slit. Dr. Ram, you wanted to say something here?
Yeah, just a comment on what you said, making an incision of 2 millimeters. I think for experts like you, it's very much possible. For a beginning surgeon, we initially started off with 4 millimeters, then gradually went down to 2 millimeters. Most often it works out well, but sometimes when you're in trouble and you have a stuck lenticule, then ripping of the incision and all happens. So I think 3 millimeters is a good via media, which allows you enough space and things are more under control. So this hangover from phaco where you want smaller and smaller incision really doesn't apply here. And having too small incision is not really helpful, doesn't give any advantage. So I believe a 3 millimeter is a good via media. It's just a small tip I wanted to give for people starting off.
I agree with you, Dr. Ramamurthy.
Yeah. So actually what I said
where we did one eye 2 millimeter comparing the other eye with 5. And we found that there was no difference in the amount of aberrations as well as the final outcome or anything. So it does not matter what size incision as far as you can comfortably do the procedure. So I also prefer to make at least 3 millimeters and not really go very small.
Yeah, so basically what I said was that the machine allows you to go up to 2 millimeters. Normally I also would go at a 3 millimeters, but I slightly disagree because when you're looking at a 5 or a 6 millimeter, you have a very large incision. The play or the ease with which you can remove the lenticule becomes a little more difficult because the incision is too large. So I would prefer to, even for starters, to start maybe at 3.54 and not go to 6 or 5 or 5.5 or 6. But typically, yes, the incision could be around 3 millimeters and that would be fine. I have never actually made a rescue incision. When people advocate, that means that you have an incision on the other side. So I really don't know. Maybe Professor Jodh Mehta, would you wish to say anything? Do you do a rescue incision at all, or did you? What size of incision do you have?
No, I've never used it. But I agree with the comments and what Ram said, that, you know, when people start off, I tell them, don't try to kill yourself. I mean, you know, everybody talking is a very experienced smile user, so they can do these small incisions. And I get people to start off with about 3 millimeters as well, or even 3.5. And then as they get more comfortable, I get them to reduce the incision. The only thing I would say is I'd add is that I do rotate the incision so it's not superior. So it's slightly to, I mean, I'm right-handed, so it's slightly to the temporal side. And that's two advantages. One, it gives you slightly better access into the lenticle. And the second is that sometimes the contact lens wearers have very loose superior subconjunctival tissue. So you reduce your risk of getting conjunctival tissue sucked into the suction cone.
In fact, Jodh, I think exactly what I do, I just move it about 20 degrees to the side, you know, to have the access. It's much better, especially if somebody has a strong bells. You know, it becomes much easier that you have access a little bit to the side on each eye. And I think what Dr. Maipal sir said was also very important, because while it's, you know, important not to have a very small, like a 2 mm incision, which Dr. Ramamurthy sir said, on the other hand, having a 5 mm or something is counterproductive as well, because it makes it so much more difficult to dissect the lenticule. And so I think ideal is to start with something like a 4 and then go down to 3 and then stay. I do a 2.8 to 3. That's what I like. Even the bigger ones also have higher risk of epithelial ingrowth. You know, so I think for some reason, the only epithelial ingrowth I got in Smile was once when, you know, the Zeiss people insisted that they were giving us a cheaper PI or something at some point, and they said, sir, you can make a pseudo smile kind of a thing. And that was the only time we got an epithelial ingrowth. And in LASIK, where we have a full flap, we rarely get an epithelial ingrowth. So I would strongly recommend a 3 mm as everybody is suggesting.
Yeah, I was not advocating a bigger incision. I was just saying that it will make a difference.
No, I'm not pointing at your this.
It's not a from anatomical separation. I think 3-4 millimeters. Okay, can we go on to
just one comment here, because
alluding
to
Ramamurthy wants to speak.
Alluding to what Gaurav was just saying, you know, it's not really epithelial ingrowth that happens in Smile, but it is epithelial implantation, as both Maipal as well as Dr. Grewal said. And I believe, you know, Rupal had come up with a paper which says that washing the interface is really not necessary routinely after this case. And after listening to her, I started doing that for some time. But now I've started washing the interface again, because I think inadvertently some epithelial cells could get in, and the subsequent rinse that you give might just take this away. This is just an empirical step that I do. I'm not saying that I've done any study on this with or without, but I think I would like to have the views of the other panelists, because we were routinely washing, then stopped washing. And now once again, we are washing even after a routine case of Smile.
I completely agree, sir. Even I've been doing that, a small gush from 6 o'clock and, you know, like a small simple one. But I noticed that Dr. Tithial sir also probably doesn't like to do the, you know, in his talk, he kind of showed that he doesn't like to do the interface wash. I've been doing it from day one, like, and I've never had a, and I agree with you that, you know, I had, you know, situations where, you know, you notice, you might notice something small, you know, going in with the spatula sometimes. I mean, 99.9% nothing happens, but that small gush kind of gives you that, unless there's something against it, sir, Tithial sir and Dr. Rupal.
Yeah, so I don't, I wash only if I feel that there was manipulation at the incision site, and that had caused epithelial disturbance.
Sir, you are muted.
But otherwise, I don't really like to enter the interface again, because that same entry can also take more epithelial cells or even debris or anything from the conjunctival sac inside. So I don't usually wash unless I feel that my incision was not, that I had manipulated the incision and kept entering again and again.
I agree to Dr. Rupal. If you saw,
I think
you saw my technique.
Even the jury is still out.
Remove the dissector also.
I think the jury is
I go anteriorly, then directly go posteriorly without taking out the dissector out also.
Yeah.
That would decrease the, you know, epithelial cell going inside.
In fact, sir, I use that hydro expression. So if my lenticle comes out the way you showed with the spatula itself, 90% of the time it just comes out because it's free. And when for that few percentage of cases where it does not, and you may have a small inadvertent attachment somewhere, I just use a hydro expression cannula to put a small gush at 6 o'clock. and most of the lenticle will come out. And I don't like introducing forceps into the interface, and then that part of the flap is the lenticle is hanging outside. You just hold it with the forceps outside and just tug on it and it comes out. But that also does the wash, and it kind of brings out the lenticle more easily for me.
Thank you. I think we can go to Dr. Shri Ganesh.
Next talk, Dr. Shri Ganesh, Chairman and Managing Director of Netradhama Hospital, has been doing SMILE ever since the SMILE was introduced in India. And he's going to be talking about implementing advanced research to reach new heights in SMILE.
Good evening, dear friends, and I would like to thank Dr. Maipal and Dr. Namrata and AOC for inviting me to this webinar on SMILE. Let me just get my slides up. I am a consultant to Carl Zeiss Meditech, and I would like to also acknowledge my colleague, Dr. Sheetal Brar, who has helped me in this research. So we will look at going to the next step where you can refine the SMILE procedure and improve patient satisfaction and get better visual outcomes. So first is, of course, we were talking about this before, but energy optimization is very important, and energy level should be optimized to prevent OBL and obtain a uniform density of the bubble layer. And for most Visomax lasers, the fluence levels of anywhere between 22 to 32, corresponding to an energy of 110 to 160 nanojoules may be required. And this varies from machine to machine and the environment. So every machine is individualized, and you will have to kind of obtain your optimal energy levels to get a very nice bubble layer. And so far, no sign was described to signify the end point where you get a optimal energy. And so we were looking at this, and then we brought out an article which was published in the GRS in 2019, and what we described the gas bubble escape sign. It's an intraoperative sign to predict the immediate visual quality after SMILE and the quality of the bubble layer. So let us look at this video, and you can see that the bubble layer is very uniform here, and there is hardly any OBL. And as soon as you open the incision, you can see that the cornea clarity improves and it becomes transparent. And then, of course, you can dissect the layers. And I want you to look at the ease of dissection. I always use a forceps to stabilize the eye and provide counter traction. But you can see that it's so easy to dissect. There's no OBL and there's hardly any resistance. And if you have a very nice bubble layer, then the post-op visual recovery also is quite good. So this is the escape of femtobubbles as the incision is accessed. And there's an immediate generalized clarity in the appearance of the interface. Let's look at another video. You can see that the bubble layer is there. As soon as you open it, you can see that the bubbles escape and then the clarity improves. So this is what we call the gas bubble escape sign. And the reason why this, okay. So what we noticed is we also looked at the OSI, that's the objective scatter index with the HD analyzer on day 1 and day 15 for eyes which had the gas bubble sign and the eyes which did not have a gas bubble sign. And we saw that there was a significant difference. You can see that the OSI day 1 was much better in the eyes having the gas bubble sign, whereas compared to the no gas bubble sign. Of course, at 15 days, also there was a difference, but it was not statistically significant. So the clinical significance is when you have a uniform bubble layer without any opaque bubbles. Opaque bubbles is basically a concentration of the bubbles, and the bubbles get entrapped there. So when you have patches of OBL, that does not allow for the bubbles to escape once you open the incision. Also, if there are any black spots, they also block the escape of bubbles. So when you have a uniform bubble pattern, then as soon as you access the incision, then the bubbles escape. And this is one of the signs which show you that your energy is optimized. So the limitation is that we were able to observe this only in approximately 65 to 70% of eyes. And even though your energy is optimized, you may not see it in all eyes. It's probably because of corneal biomechanics, which vary from eye to eye. But generally, this can be a useful indicator of the energy optimization in SMILE, and you can also use it to predict your immediate post-op visual quality, and it may guide the surgeons for fine-tuning the laser energy. So once you have optimized your laser energy, again, Dr. Tithial spoke on techniques, and this is a technique which we described, lenticuloschisis, or a no dissection technique. And this was published in 2017 in JRS. And let me show you the video. This is actually, this should be attempted only once you have an optimal energy level. And then if you have OBL or if you have black spots, then it's not ideal to use this technique. You should also be fairly skilled. So this is a technique where you directly enter the interface with your forceps, open the jaws, grasp the lenticule on either side, push it down. And you can see it was so transparent, the cornea, because of the gas bubble escape sign. And then you can just peel it off. And this is all it takes, just a few seconds. And you don't have to do an interface wash. And what we saw post-op clinically, if you see the two images, we compared the dissection technique where we used a spatula and the no dissection technique. In the dissection technique, you see that the interface is rougher and you have a prominent cap edge. That's because you go to the periphery and you're pushing with your spatula, and that stresses the bowments and it expands the bowments, because the bowments is a plastic layer. And because of the expansion, you get bowments wrinkles, and that can affect the quality of vision on day one and the scatter. And that's why we looked at the objective scatter index. And in the no dissection technique, you can see the retroillumination photographs. The interface is much clearer and uniform. You don't have any rough spaces. And if you see, there is no prominence. You can hardly make out the cap edge because you're not pushed and you're not gone to the edge. You can see, you can't make out the cap edge. So this is probably the reason why the first day quality of vision is better. The other very important research that we just did, and of course this is under review for publication, is differential spot spacing parameters. Now, conventional practice is to use the same spot distance for both the cap and the lenticule. Oops, sorry, I've just jumped. But then if you look at the cornea, you can see that the structure of the cornea is not uniform. You have the superficial layer where you have thinner collagen, and which is more compact, and the deeper layers where you have the thicker collagen and then wider spacing and gaps. It's like Swiss cheese. Okay, so you have the thicker and wider collagen fibers deeper and thinner. So it makes the cornea is not uniform. So it makes sense to have a differential energy for the superficial and the deep layers. But you can't do that, because if you have differential energies, then the laser has to stop and recalibrate, and it takes more time. So what we thought is we'll have differential spot spacing. So the energy per square millimeter will vary between the superficial and deep. So we used a spot distance of 4.5 for the superficial layer and a spot distance of 4.2 for the deeper layer. So you had closer spots, so the energy per square millimeter increases. So you had more energy in the deeper spots because the fibers are thicker, so you need a little more energy to cut the thicker fibers. Oops, jumping, sorry. So this was a contralateral eye study, 100 eyes, 50 patients with spherical equivalent more than 5 diopters eligible for SMILE. In the conventional technique, we used an energy cut index of 30, spot distance for 4.5 for both the cap and lenticule cut. And in the differential spot group, we use an energy cut index of 28, and the spot distance was 4.5 microns for the cap cut and 4.2 for the lenticule cut. Now we scored, the surgeon scored the ease of post-op posterior plane dissection, and from 1 to 5, 1 being very difficult and 5 effortless. And in the standard spot, it was 2.4. In the differential spot, it was 3.8. So there was a significant difference in the ease of dissection of the posterior plane. We also looked at the uncorrected distance visual acuity, day 1, 2 weeks, and 3 months. And we found that with the differential spot, the uncorrected vision was much better. This is a contralateral eye, so the corneal biomechanics is equal. At 2 weeks, it was not that significant. Again, at 3 weeks, it was significant. We also compared the OSI, the scatter at day 1, 2 weeks, and 3 weeks. And we found that the OSIs were much better with the, much lower with the differential spot than the standard settings at day 1, day 2, and week 2 and 3 months. 3 months, of course, it was not statistically significant. That's probably because the interface had healed. So as a routine now, we are using this. We keep 4.5 for the anterior and plane and 4.2 for the posterior plane. The other study which we did was small versus medium cone for smile, because what the company recommends is that you look at the white to white and then select the cone, the horizontal white to white. And if it's less than 12 millimeter, you use a small cone. If it's more than 12 millimeter, you use a medium cone. But when we looked at the bubble pattern with a small cone, we used to get a uniform bubble pattern for the same energy. With the medium cone, what we found that we used to get more OBL in the mid-periphery. You can see very clearly that the OBL is much more in the mid-peripheral area, and the dissection was a little more difficult, and the visual recovery with medium cones also. Day 1, the vision was not as good. So we did this clinical study. This was to compare the visual outcome and quality of vision using a small versus medium cone in patients with large corneal diameter, more than 12 millimeter, undergoing relaxed smile. This was a randomized contralateral eye study, 60 eyes of 30 patients, and relaxed smile was performed using standard technique. Post-op regimen was similar. Follow-up was day 1, 2 weeks, and 3 months. This was the uncorrected visual acuity, and you can see in day 1, the group with the S-cone had a significantly better visual acuity, uncorrected visual acuity, and even at 2 weeks it was better, and 3 months also it was better, but it was significant on day 1. We also looked at the OSI, which is the objective scatter index, which gives us the quality of vision, the quality of the interface. And we saw that with the small cones, day 1 and 2 weeks, it was significantly better than the medium cone group. At 3 months, again, it was better, but not statistically significant. So if you look at LASIK and corneal diameters and how you select the flap diameter, there are various tips and pearls which have been published. But however, smile is different from LASIK. Smile, the cap diameter is fixed, and maximum you go to 8 millimeters, because the white to white is not as critical. Maximum you may use an optical zone of 7 or 7.5 millimeter, and you can use a cap diameter of 8 millimeter. Usually you don't go more than 7 millimeter because it consumes a lot of tissue, and it is not required because pupils are not bigger than 7 or 7.5 millimeters. So using a small cone for all cases of smile is preferable. Again, the small cone ensures better fit because the radius of curvature of both the small and medium cone is the same. But what happens is, as your diameter increases, the sagittal height increases. And when the sagittal height increases, it becomes relatively steeper, like a contact lens. The same radius of curvature, if you increase the diameter of the contact lens, there's nothing but a contact lens, then you get a steeper fit. So when you, with a small cone, you have a flatter fit, it fits very well. With a medium cone, you have a steeper fit. So you have to compress the cornea, you have to do a hard dock. You can't do like an 80% dock. And when you do a hard dock, you have more compression of the mid-peripheral tissue. And that's why you see that OBL because of the compression. So that is, again, this is under review for publication. The other work which we did was cyclotorsion compensation, where actually, of course, with SMILE, there is no tracker for cyclotorsion. And we all know that cyclotorsion can occur because of various reasons, just static cyclotortion when the patient lies down and you have done all your measurements of the cylinder and the axis with the patient sitting up, and when the patient lies down, there can be some amount of cyclotorsion. Now, it is very important to compensate for this. Of course, some studies have shown that it doesn't make a difference. But again, if the cylinder is very small, and what we found is that in 85% of patients, it doesn't make a difference. In 15%, there is significant cyclotorsion, and these patients have to be compensated. Otherwise, you can have loss of BCVA. Now, how we do it is pre-op 0-180-degree marking is done using the either the Akoshi or the Ganesh bubble marker. You can use an infrared transmitting dye, which is the viscose surgical skin marker, and patient is positioned under the VisuMax, instructed to look at the green flashing light. Then the docking is done. I'll show you the video. This is the publication 2017 in GRS, and then following this publication, in fact, Zeiss has given a recommendation that manual compensation be done in cylinders more than 1.5. We found that in higher cylinders more than 1.5, or if your sphere is less and then you have more of a cylinder and then more than 1.5, then there is a chance, there's like a 15% chance that you can have significant cyclotorsion. Of course, if your study group is small, just about 20-30 eyes, then most of them may be within that 85%, you find it is not significant. But it is common sense, whether for any astigmatism, whether it is for LASIK, PRK, SMILE, toric ICL, toric IOL, you have to be on axis. Otherwise, it can undercorrect the cylinder and you can have induced abrasions. Even for a contact lens, you do a prism ballasting for a toric. A contact lens is nothing but a lenticule which is there on the eye, and you do a toric prism ballasting. And even when the patient blinks, when there is a slight movement, the quality of vision reduces. And patients wearing toric contact lenses know this. When they blink, the contact lens rotates a little, then the quality of vision reduces, then it settles down. So it's very important to, and all the new machines coming out now, the SMILE machines will have cyclotorsion compensation. So here the eye is docked, suction is applied, any cyclotorsion is measured. You can either use the reticule as a reference, or you can use the screen as a reference, and then the cone is rotated to align the two. And if the difference is high, more than 10 degrees, sometimes we see up to 15 degrees, then it's better to redock the eye, because if you move the cone too much, there is a risk of suction loss. So this is how you do it. After you dock and then you put on the section, you hold the cone, and then you can see here, there's almost a 10-degree cyclotorsion. We rotate it before firing the laser, because if you don't rotate it, then the cylinder is off. And we also have a study with the control group. Gitansha was saying about the control group. We did a retrospective study, because knowing well that cyclotortion kind of improves results, it's unethical to do contralateral eye or two groups. So we just did a retrospective analysis of when we are not doing cyclotortion, and then when we started doing cyclotortion. And what we found is that gain in lines is much better in the cyclotortion compensation group. It is significant. So now I have devised a 3-point epithelial marker, because when you mark with ink, what happens is the ink can spread. And if you don't use an infrared transmitting ink, then it can block the laser. And if the ink spreads, then that itself can give 3-4 degrees difference in marking. You need a sharp line. So I have a 3-point epithelial marker. This is an inkless method. It gives you linear marks at 3, 6 o'clock, and 9 o'clock, 3 reference marks. You get long marks visible after you dock, and the epithelium is indented slightly. It does not lead to discomfort post-op, and we see better results now. So those were few of our few of the research that we did and publications which help you to get to the next level in SMILE. Thank you very much for your attention.
Thank you very much, Shiri. You just said that all the new machines will be with the cyclotorsion adjustment that you can get. How soon is that?
Yeah, the Schwinn machine which has come out already has cyclotorsion compensation. And I think the newer devices, there are a few. I'm not at liberty to speak about it extensively as I have an NDA. So most of the machines coming out now will have cyclotorsion compensation because it is significant. Even your spectacles, if you're wearing spectacles and you have a cylinder and you slightly tilt it, you will see that your vision gets distorted.
There's
so
no
the quality of vision.
Yeah.
So there's no argument that the cylinder has to be on axis, right?
There is no argument about that. I'm just asking because even in my slide, I said that there should be a cyclotorsion compensation.
Yes.
So VisuMax is also going to get it. VisuMax is also going to get it, right?
All machines will have to have it.
Okay. ND. Professor Jodh, I think you have to leave. Would you want to give any last final comments on anything?
I was just going to add to just one comment that Sri made. He talked about the cone. It was very nice talk. The only thing I would say is that, so we use a small cone, but when we program the machine on the bottom, all you have to do is press medium. The machine thinks it's a medium cone, but we always use small. And that will allow you to do a larger lenticle if you ever need to do it. So you just fool the machine. It's very simple.
Yeah, but there is a caveat there. You can't go more than 8.2 millimeters. If you go more than 8.2, then it crosses the, So the maximum you can go to, that is the Dishler technique when you're doing femto-LASIK, where you use a small cone, but you program a medium.
Yeah,
right?
you just tell the machine it's a medium. Yeah, you just tell but we do that.
So, but you can't go more than 8.15 or 8.2.
Sure.
Because if you go beyond that, then your side cut is going to go out and then it's going to create problems.
Absolutely. But you're going to use a smaller, the advantage of doing that is that reduces your risk of inducing any suction loss because your suction is going to be truly on the cornea, because most of our white to whites are very small here, you see. And so you'll have a much lower risk of getting a suction loss. But if you ever need to adjust it, you can we always do it as a routine, but we never actually go beyond 7 millimeters, 6.8 millimeter lenticle.
But you can program a small itself for SMILE. Only for LASIK it's required. For SMILE, you always use a smaller zone, right? You never go beyond.
Once in a while we use 7. Once in a while I use 7, especially in larger pupils, but not that common. Not that common. Yeah.
I wanted to ask the same question, and do you
Thank you.
You said small cone is better than a medium cone, but do you think there would be ethnic differences? I mean, it's okay.
See, even if you have a large, we did this on eyes with over 12 millimeter diameter. So even in the 12 millimeter, if you use a small cone, there's no issue for SMILE. You don't get any problems. You just have to center properly and then dock, and then you can do it. And you don't have to use a medium cone, because when you use a medium cone, you have more compression and you have to do a hard dock, and your OBL increases and your visual recovery. I think most of you all who have used a medium cone would have noticed this also. But only for hyperopia, you have to use a medium cone, because for hyperopic SMILE, you have a very large transition zone and a large optical zone for the stability. So you can't just use a small.
Okay. I think, yes.
I very much agree with this. We have almost completely given up using medium cones, use only small cones for SMILE, mainly for the fact that we find that the chance of suction loss is much less than that. Of course, Sri alluded to other points also. The only way we cheat the machine is when we are using the VisuMax for creating a flap. In that case, we use a medium cone and feed the machine as large. So we circumvent the problem.
No, you can use a small cone and program it as medium. That's the Dishler's technique.
No.
So then the OBL is less, and it's much easier to lift the flap. If you use a medium cone and program a medium cone and use a medium cone, then the OBL is more, and then you have difficulty in lifting the flap. So this was published by Dishler.
I'm making a distinction between the smile lenticule and doing creating
LASIK itself.
LASIK
Flap only.
Yeah,
Yes. Flap itself, that's known as the Distler technique, where you use a small cone but program a medium cone. Large basically is not required
you
because
you have a restriction of the diameter that you can get as far as the flap
8.2. See, 8.2, but LASIK also, you don't want to use too large a flap, right? Because and most of the modern machines, your transition zone is not more than 0.7. So even if you're using a 6.5 zone, you will go to a 7.2. So if you program an 8 mm flap or an 8.1, up to the 8.2, you can go safely.
Well,
so that's what we do.
Maybe a hangover from our earlier days, we use still a 9 mm flap as far as LASIK is concerned. So
no, I think we should avoid using a 9.5 or 9 mm, because what happens is that weakens the cornea. As you're cutting, you go more periphery, you're cutting the peripheral fibers, your incidence of dryness increases, and your biomechanics also gets affected because the peripheral fibers are very important for biomechanics. So that's again something which I wanted to discuss. When you want to do a study on smile versus LASIK for biomechanics, I think you should use the same kind of diameter. In smile, if you're using 7.5, in LASIK also you use 7.5 or 7.8 and then compare it. And you should not use a 9.5 and compare it with a 6.5 lenticule, because that doesn't make sense. Unnecessarily, you're cutting more of the cornea.
Okay.
I think, thank you, Shri.
Excellent. Let's go on to the second part of the webinar now, and we'll be going on to the commerce and how to get in patients and how to keep them satisfied. So, Dr. Namrata.
Yes, so the next speaker is Dr. Ritika Sachdev Gupta. She's been a student of RP Center. She's been to all the dream institutes or the medical colleges that one can dream of in one life. She's done her MBBS from Lady Hardinge Medical College, her MD from Maulana Azad Medical College, her senior residency from RP Center, AIMS, New Delhi, and now she's the director at Center for Sight Group of Eye Hospitals. And we are very proud of her from RP Center because she has been at RP Center. She's a great academician, very hardworking, and now a very successful entrepreneur, if I may say, and a very successful person in practice. And she's the most apt person to give this talk on growing your refractive practice by reaching out to millennials.
Thank you, ma'am, for the very kind introduction. Is my screen visible?
Yes.
Good evening. I'd like to thank AIOS for this opportunity and Dr. Namrata for always encouraging me since I think almost a decade now. I'll be talking about marketing to millennials. We are now looking at a change in the marketing landscape of refractive surgery, and I'll be covering the aspect of the change in context with regards to new technology and the new generation that we now have to communicate to. We've all witnessed a great hype and a great wave which came with LASIK. But in 2007, the number of procedures that were being done in the United States of America have halved in 2017. So there was something that was amiss. Perhaps it was the economic slowdown, but there was also an increasing number of eye laser centers and a price war, which traded value for price, which did not benefit the patient or the doctor. Now, as we are to recreate the future of refractive surgery, we simply can't do it by repeating the past. There are certain highs that have come from the previous low. The first is that refractive surgery is still an under-penetrated market. The funnel is not wide enough. Only 20 to 30% of the people wearing spectacles are aware and thinking of refractive surgery. So we still have 70% of market to reach out to. The consumer confidence index, though goes down, it does come back and the economy is rebound. Also, the low has withered away a lot of discount dealers, and we finally now realize that price has to be not played as much as value does. We've had a similar experience as the LASIK wave moves down. We've had centers with multiple LASIK units, but the 4 centers of ours which really did the best and which stood the last decade were all centers which had the SMILE machine. So SMILE really was a missing piece that allowed us to reinvent and communicate our refractive practice to the consumer or the patient. Why it allowed us to do so is because the benefits are tangible. When you tell a patient this is a one laser, all laser, bladeless, flapless procedure, he actually understands it. The wavefront guided, wavefront optimized, this was all jargon that was created for marketing and was explained to patients in various ways to convince them, but never really resonated with the patient in terms of a tangible benefit that not having a flap can give them. Also, having SMILE gives you the uncluttered communication to patients who had previous bad reviews of LASIK or are scared of flap-related complications. Most of the SMILE surgeons have evolved from LASIK surgery, so you obviously don't let go of LASIK and you have a tiered pricing to continue to cater to patients who can't afford the premium procedure of SMILE. But you will be surprised that 70 to 80% of your practice will still migrate towards the premium procedure. Now, whenever we look at a marketing and sales funnel, at the top of the funnel is creating awareness about the technology. And this is where we have a lot of SMILE users. I think the technology has stepped up. It's time that we step up and create a greater funnel of awareness for SMILE like other technologies are doing. So if somebody is searching the internet, they should get enough information about SMILE. The second is what we as practitioners sometimes work off, which is the middle of the funnel. That we don't work on creating a larger awareness of SMILE, we work on creating an awareness about our facility for SMILE. That is the middle of the funnel. And the bottom of the funnel, of course, is once the patient has come into your center, give him the experience, counseling, and conversion that you need. So the top of the funnel is something that is exciting for all of us to create a cake that this technology really deserves in terms of the refractive landscape. The previous way of creating awareness was, of course, with press advertisements like newspaper advertisements. You see, this is an old creative, the name Relax Smile instead of Smile. And we are basically communicating an experience beyond LASIK. However, millennials are different. I'm part of the millennial generation. We were born with technology. We grew up with technology and we do trust technology. So this is a digitally native generation. For us, technology is like talking to a person. Technology or internet is not a yellow page anymore where you can just list yourself and people look you up for an address. Technology is where you tell people what you are about or what the technology is about. So it is communicating a slice of life or giving people engaging stories. Do note that people are not only looking at what you're saying, but what others are saying. So it's very important to create a communication about the technology. Though millennials are cost conscious and unfortunately our generation has less money than the previous baby boomers, but they are very conscious of value and they're willing to pay more for something that adds to their life and are open to EMI options. They're also looking for a personalized experience. They don't want a factual information about what a technology does. They want to understand how that technology fits better into their life. For example, a sportsman would easily resonate with SMILE because it's something that leaves his cornea biomechanically safer. So all in all, millennials are on the internet and that's where we need to be. The Google searches have increased tremendously, but in India, it is the mobile searches that have increased tremendously. So whatever information we give or the website that we create has to be mobile friendly. Do note that, yes, we may think that the internet is something that may be a upcoming trend, but it's actually already there, particularly in larger tier 1 cities and metros. 60% of healthcare needs begin with an online search and 70% plus patients who walk into your hospital have actually visited your website. So how do we get visible as regards technology and providers? There is an organic way wherein if you're old enough, relevant enough, Google will spot you when patients are looking for SMILE. Of course, you sometimes cannot be spotted and therefore you have the inorganic or the paid way, wherein if people are searching for laser vision correction, you push your content to them. This is an example from a telephone. If somebody is searching for S20, this is an ad that Samsung has thrown up. So they have pushed their content to the consumer. But because their website also has relevant content, even if they don't advertise, Google will realize that they are relevant and show them to the consumer who is searching. The trick with SMILE is that SMILE is not a very searched word. And when you search SMILE, you get a lot of dental results. So it is very difficult to optimize SMILE on Google. we still have to optimize what the consumer is searching, which may be laser vision correction, chashme se chutkara, spectacle removal, or LASIK. So the keywords you have to look at have to be relevant to the consumer in your geography. And though we may appear if a person is searching for smile, sometimes there's just not enough people searching for smile, and you have to catch them when they're searching for LASIK or other popular technologies, and then give them the content which convinces them about the technological benefits, which are many. Irrespective of how you push content, you have to get them to a relevant part of the website. If somebody is searching for refractive, don't get them to the home page of your website. People don't want to maneuver. They want curated content. So from a Google AdWord, they come to the content of your website, which then gives them the relevant content so that they don't get lost in the maze. Of course, Google is king, but there is a lot of social media that allows you to communicate, be it Facebook, Instagram, Twitter, LinkedIn towards corporates, or even a simple WhatsApp. What is even more important is the amount of people talking about Smile, which is the general online buzz. You create that with platforms such as Quora and creating great patient blogs, wherein you have people who underwent Smile who can influence other people on the internet. So this is something I think as Smile users, we should actively work on. There is a lot of spam that has been generated against Smile, and you cannot control, unfortunately, or censor the amount of spam on the internet. The best way to drown false content is by giving patients true content. And one thing which is really a characteristic of the millennials is that we value authentic content. And if you can show that a lot of the content which is out there is spam or a myth, it is something which will make that content spiral downwards and make the customer shift to people who are giving an authentic service and real facts. The sample creatives have also changed because millennials, like I said, want to talk about their life on the internet and not just facts. So you can talk about technology and of course give the technological benefits, and simply the fact that, like I said, you have to use LASIK first and then introduce them to Smile in many cases, because they sometimes don't initially know what Smile is. You can shift the content to make it more personalized. For example, in the previous content, it was about technology. This is something that appeals to you because there are a lot of young people who get likes on their pictures. So you're just trying to tell them you'll get more likes. This is the content which have, if at 2 a.m. when she cries, would you want to look for your spectacles? So it is connecting to the life of a young mother. This is a campaign which is about superheroes and giving the millennials a feel of an enhanced experience throughout their life. So these are slice of life stories which give them an experience they will value with a technology they can trust. So you always cannot just talk to them about a cold technology. You have to talk to them about the fact that they have a trusted technology which will add value to their life without any risk. This is another story of a dancer which we actually showcased how her life changed. And this is an authentic story. And like I said, mark the spam as and when you see it. And as a doctor also, just creating a simple profile on Quora and answering questions is a great value service that you will do to patients because you'll give them authentic content. Bust the myths around Smile. I think we're all convinced, but it doesn't happen if only you're convinced. You have to tell and communicate the truth to everyone. Though price is not a point that you should play on all the time, you still have to give those sporadic false flash sales, because India is a diverse country and we have enough people who aspire for a technology but need that flash sale simply because they value the discount as much as the technology. Now you have various platforms to run your ads on, but what is very, very important is please target the right TG. If you have a practice based out of, say, Delhi, you would want to target Delhi. You may not want to burn money in Chennai. And you have to look at patients, at the behavior of the TG that you want to target. You may not want to target a 60-year-old. You want to target a 20 to 40-year-old, especially if you're doing press buy on. You also have inbuilt analytics, wherein once you have given the Facebook or any media details about this is a relevant lead, they will match that lead and give you more leads like that, which is called like-to-like marketing. So when you do get a patient which is relevant, do backfeed that data and analyze that this is a relevant lead so that you can get more like it. Whatever content you create has to be captured, because if somebody has learned about you and not able to reach you, you've burnt money. That is where you have either a landing page that is created or get them to the website. A landing page is better because you can have some specific offer or some specific news on that. This is a seminar that we had on LASIK, wherein the person was invited to the center and given a talk by the doctor about the technological advances. Content marketing, like I said, creating short videos, particularly in vernacular languages, which are less than 5 minutes, creating blogs, articles, and small GIFs and presentations and uploading them on SlideShare, Quora, multiple, and even Facebook is something we as satisfied surgeons should do as a service to the patients and other surgeons. When you do get a customer, please make sure that they write about it and create an authentic whirlpool of good feedback. Because word of mouth is today Google review. So make sure that these people have something to write back about, and you can accelerate the word of mouth through this. Internal branding will be spoken about in the next talk, but you must talk the same language once the patient enters your center. If they know you're a smile center, the inside should also show the advantages of the smile. What's most important is that you do burn money to get leads. Once these leads are there, you have to capture them and convert them. And you must continuously remarket or re-engage with leads that have not converted to appointments. You must track them. Whenever a lead is there, we've actually faced this problem. There are people, including competition, that put robots and give you false lead, and your call center is calling and they're getting no returns. So therefore, you must have something like a CAPTCHA code that actually filters the robots filling in your lead. If you look at a lot of startups, they actually have forms where they offer you 10% discount just so that you give them the entire data that they need in order to capture your likes, dislikes, and put you into their CRM. So you can even have an offer for like a free smile screening, but not a price war, because we don't want to go there again. So like I said, leads have to be scheduled and converted. You must analyze what people are thinking about your campaigns or about the stuff that you're putting out. There are a lot of tools, some of them are free, where you can capture the sentiment of your hospital or even yourself or even the technology by putting in the keyword. You have to see what are the number of people who are neutral, positive, or negative about anything. You also should continue to see what the competition is doing, because that helps you learn, and also it helps you understand what is working and what is not. I was pleasantly surprised to see that a lot of the major eye care hospitals have actually rehauled their website in this period of lockdown. So I think there is a cognizance of the fact that we need to continue to evolve digitally. The price war, like I said, got us nowhere. And I think Smile, because of the high cost of the PI, we anyway cannot start a price war. But this generation is about putting value. So don't confuse affordability with pricing. Just add value to the experience, and the technology already has a great value. And financing options like EMI or part payments are a great tool to enhance conversion. So my top pearls is that this is a new generation. Choose the right media to communicate to them. Don't give them facts, give them slice of life stories and stories of other patients and you as a surgeon. Internal queries must be tracked. Let's not start a price war. Let's add value and affordability by EMI options and focus on experience as much as the outcome. I think the best definition of brand I learned was from a great entrepreneur. He said a brand is nothing but a promise kept. So as an organization, as a surgeon, we would like to keep our promise to the patient. And as a Smile user, I think the technology definitely keeps the promise. So it's a great combination of creating a great brand in refractive surgery. Thank you for your attention.
Thank you, Ritika. I think that was a really power-packed presentation straight from the heart. And that is something which is not given in the books, something which is not so compositely, given even in the digital media, but you just put it all together out of your own experience and out of what goes into making a practice of refractive surgery. I think it was the finest presentation on practice of refractive surgery that I have ever heard. So are there any questions, or should we move to the next talk, sir?
I think Anybody has any comments? Otherwise, we can move to the next talk.
Okay, so we move to
I think I should just acknowledge that Ritika spoke so well that, I mean, it was fantastic listening to Ritika. I mean, engrossing and made a lot of sense. Thank you.
Surpassed everybody today, I think.
I was just asking Maipal, can you lend up for a month or so?
No, he can't. He's already lent one. He can't lend another one.
Yeah, he's already lent one. He can't lend another one. And I was going to tell Ritika that she spoke too much.
No. She was too good today.
No, I think if all Smile users come together, we'll create a great whirlpool. So I actually request all Smile users to create more content on Smile. It will benefit us all. And we are all authentic people, so we'll create authentic content and the patients will recognize it.
Ritika, here I would think that while we should all come together, as you said, I think Zeiss has a very important role to play here. They have all the resources available to them. They can help us, with content creation, which can be put across by all the Smile users themselves. I mean, that can be one aspect. And of course, patient testimonials and other stuff which you mentioned can obviously come only from us. But I think at its end, Zeiss can kind of create like they created that campaign recently during COVID where the mask was, the glasses were getting fogged with the mask and stuff. Similar to that, I think every month if they come out with 2-3 new things which can be in different ways posted on different ways of social media or digital marketing, and it would go a long way. And at our end, of course, as you said, we should all collaborate.
And I think we should all mark out the spam that is plaguing Smile on the internet. As active users of Smile who have active patients, it's time to just call out the spam.
Absolutely. I've been telling you that about a year or so now. So yeah.
Dr. Garewal, you want to say something? Because I think you were somebody who has pioneered digital marketing. Is he there, Dr. Garewal?
I think he's not there, sir.
Okay, maybe we can thank you, Ritika, for an excellent talk. Always nice to listen to you.
You listen to me very often.
On stage and off stage both.
It's always nice to listen to you. Great.
Okay, with this we come to the next talk again, which is related to the practice of the Smile. And the next speaker is Dr. Safala Shroff, Hospital Administrator and Laser Eye Surgery Counselor at Shroff Eye Hospital in Mumbai. And she did her post-graduation not in ophthalmology, but she's changed her line completely. And she's going to be talking to us on role of support staff in boosting your refractive practice.
Thanks, Dr. Sharma. Am I audible?
Yes.
And the screen is visible?
Perfect.
Okay, thank you. And good evening to all of you. And thank you to Dr. Maipal, sir, and yourself, Dr. Sharma, for giving me this opportunity. There were excellent talks with a lot of science and technology. And Dr. Ritika just added like the cherry on the top, saying that all that has value when we can market it to the target audience in the correct way. Because as you know that everyone has spent a lot of time, money on technology. So my talk takes on from that, where the role of staff is important in counseling and how they can play a role in helping us with improving our practice. So I don't have to really tell about the benefits of having a separate counselor, because as we know, we can't be in two places. So they do definitely bridge the gap between the surgeon and the patient. They reduce the chair time with the surgeon. Important is this as that they're available when the doctor is busy. And it's possible that as your practice grows, we may need more than one counselor. Sometimes I've seen in our practice that for patients of refractive surgery, you need a different skill set as compared to someone with maybe who's going to talk to a more mature audience for cataract. So when we hire staff who are going to represent us, be our brand ambassadors, we look for good body language. They should be presentable. And the second point is extremely important. That is active listening skills. And it's not just listening. It is to be a good judge of what your patient requires. What exactly is the patient wanting from us? And for this, the staff have to have willingness to learn. They have to be self-starters. I always tell my staff that, I can teach you the skill, but the will comes from you. So they should have problem solving skills, that they don't sit on a query for a long time. We know how important the marketing department is, and they're spending so much. So after the queries are made or inquiries come in or leads, like Dr. Ritika said, the problem solving skills should play in to reduce the time to return back to our patients what they require. And this can happen by us upgrading their skills with various practice development programs, attending seminars like we are doing right now. So how I train my staff is what I'm going to walk you through. Is I tell my staff is that our main strength you should know. So list the USP of our center, and USP is our unique selling point, and here be specific, because if I am confused, my brand is going to be refused. So in this, my surgeon is unique to me. His experience and his training should be made aware to my staff. The center's infection control protocols, many centers have invested in accreditation. So the staff should be aware of these points, and technology. And this is where centers who are doing Relax Smile stand out, because most of them that I know, or almost all, have LASIK as well as Relax Smile. So if a patient is looking for a laser treatment and you have an entire range to offer them, they get a better chance of getting an appropriate laser treatment with you. So it's best that we can offer a wide range so that you can be in the consideration category. I use this brand mantra when I train my staff. It's an acronym called Kya Bolu. K stands for knowledge or Gyan. Y is our refractive practice in our country is mostly the youth. It's younger customers. We should know what they require. Attitude, the benefits. What are the benefits from doing a laser surgery for them? We have to know the occasions where we can do certain marketing or conversions. Loyalty is an important point. And I use this mantra as use and no excuse. So coming to knowledge or Gyan is what are the different types of laser treatments. Now, most often we train our staff with what only we have. We fail to tell them what is there outside of us and what is available in the world. And that is important, because when an inquiry is made, they should be aware of all the brand names as well. A simple example would be like the generic names of medicines, and to know the brands of them. This is how I give them examples. And just like we update our knowledge as doctors, patients are updating theirs as well. And with the previous presentation, you saw that they are a young generation looking out, doing a lot of work on the internet and already forming a perception before they come to us. So in our clinic, we will use posters, videos, flyers, brochures to communicate. And we have to keep our lingo, our language with a simple manner, with just common sense and not just jazzy terminologies. Coming to the why is the youth is our customer, and here I pay heed to our customer needs. And youth is a serious category. They want to look good, they want to feel good, they want to improve their confidence by doing laser refractive surgeries. Some of them choose it for careers or for social reasons, and trust me, they do the research. So important is I train the staff to capture as much as information as they can when the patient visits or even makes an inquiry. And then we do surveys with various factors like occupation, age group, language they use, and all this data should be captured from your medical records. Attitude goes a long way. And just like a doctor who participates in new advancements, new technologies like Relax Smile, my counselor should have ability as well as availability. And attitude by patients was upheld over skill and technical know-how. And this is very important for us to know, because patients already who have chosen you or considered you, they know you're competent. That's why they're already coming to you. So I have to train my staff to say that important is not to tell them what to do, but I tell them what not to do. And that is, don't make the patient unhappy. It's as simple as that. And when you see a little bit deeper through studies as to why clients leave, and you'll see 9% are lured away by competition, 14% are dissatisfied with the product or a solution you offered. And this is why I said it's important to be in the consideration category. So those who are doing LASIK, if they add on Relax Smile in their practice, you'll at least be considered. But 77% dislike the attitude of just one person in the organization. And this is why I do not just focus, like we train only counselors, we train only front desk. I train all. I train from the security department and even the housekeeping, maybe not in great detail, but the whole idea of why it's important for us to retain patients. Benefits. Patient ko kya faida hai? The staff have to know this. Physical faida, no glasses, fogging is an issue. And today, of course, with mass fogging is definitely an issue. There's emotional faida when patients are coming to us when they're seeking it for during the wedding time. Many patients actually see the financial faida also, and they see that it makes more sense and it's relevant in the long run to save money by not going ahead with too many glasses and contact lenses and actually considering laser procedure. And some have specific faida, that is they have contact lens allergy or they have issues because they are driving at night. Some are international students, so parents are worried about them going abroad and then losing glasses, or how will we manage lenses. So for us, important from our practice point is when I speak to patients, we listen. And we listen what is a specific benefit for them. Occasion, I always tell the staff, avsar dhundo to communicate. And when you collect information from patients, I say add verbatim. Don't mix it with what your perceptions are or your, assuming what they need. Write down their needs, add verbatim. And this helps us even for marketing, internal and external, because every lead is important, whether that inquiry was a call, it came by a WhatsApp, email, social media, every lead is important. Another thing we create is a list of testimonials that can help us when we speak to patients. And I've seen that if we give a good enough information, we've rarely relied on them needing someone else to be convinced through. So, but in case there are patients and you want to go an extra mile, you can always tell them that we have patients who are just like you, are international students, are living abroad and have done Relax Smile. So maybe speaking to them will help. Loyalty. This mantra I use often, that grahak se yari is equal to aapke brand ke liye wafadari. So an example is a Shopper Stop loyalty card. Of course, it's not that we want to market in a marketing sense in our practice, but to use marketing terminologies, what do we really sell? We are selling a life-changing product. But is that what the customer wants to buy from us? He already knows that he wants this product because that's how he has surfed on the internet, or he's spoken to someone and come to you. What he wants to buy is actually brand experience, quality, prompt delivery, and after-sales service. So today's youth are actually looking at investments from this point of view. This is another mantra I use, that is use, not excuse. So my staff are trained not to make excuses. I won't want to hear prices high, because misuse will say quality is high, the fee is for quality. Mr. Excuse will say market is down, corona hai, so market is down. Misuse will say there is no market for the eyes. Eyes are always there. Market is not down if your spirit and mind is up. So open your mind and open your eyes. Mr. Excuse will say this is off season, but misuse will say every day is on season. There is no season to but there is always reason to buy. So we have to open the minds of our staff to be able to help them, understand what our patients require. And sometimes I find that I have to make them unlearn what they have come with. Sometimes we hire staff from marketing backgrounds, MBAs, and they've been trained to do hard selling techniques. But the patients see through hard sell. So I stress on more passive ways where you think from the patient standpoint and see what solutions they need. So effective communication comes from when we listen more and talk less. This is the way we build trust with our patients, when we are persistent in our efforts, when we insist on results, and we are consistent in quality. Now, one will say that this is all good, but then how do I know that my counselor or my staff are doing a good job? How can I know that I'm getting a return on the investments that I have been making? And this in marketing lingo is called key performance indicators, or KPIs. And simply, if you can't measure it, you can't improve it. So the key is to choose the KPIs that are most relevant to our industry and track and monitor with regularity. So now this is again marketing lingo, but how does that translate to us? If I know the percentage of leads that were coming into the organization, how many of them converted into consultations, and how many eventually became surgical patients. Also, client acquisition rate, that is non-qualified leads. We never expected to even market to them, but they came with example for cataract for their parent, and they decided to undergo a relax smile because of the subtle marketing the staff is able to manage, or an overall conversion rate. And this gives me a good idea of how the departments are working in tandem, if there's good cross-departmental efforts being made in the right direction. And like Dr. Ritika's talk, you see that leads, that we spend a lot on creating leads and bringing it into the hospital organization. So when we know that the coordination is happening between all departments, it's a good sign. So chase every lead that comes in from whichever department it is. Feedback forms also help us when we are specific and we ask feedback on staff. From our end, we do daily task sheets when the staff is definitely new. They have to write down what they've done for the day, and weekly monitoring from our end. This is a sales funnel very commonly used, but to us, what it relates is like, for example, the larger part of the funnel, that's stage 1, is when we have the generation, that is the phone calls, the mails, those are the leads. Then it goes down, it trickles down to only 100 prospects because only 100 would take an appointment, and further becomes smaller when the customers are even reduced. That is when we've actually earned money from them and generated revenue. So our goal is to have maximum inquiries but minimal leakage at every stage. That's very important. So how does the staff play a role in this? Most of us think that sales improve when inquiries are maximum. So we end up spending more money on getting inquiries, more time and efforts in that, but this is not true. Conversion improves when we reduce the leakage, when the leakage is minimized. So for us, this means data and analytics, a strong patient CRM, that is customer relationship management system, well-trained staff that do not let an inquiry fall out easily. And this can happen with us monitoring with regular reporting systems from them across your private practice. So thank you. This was a short talk. I hope that this helps us build our practice and take us to the next level.
Thank you so much, Dr. Safala, for that great talk and for all the practical tips, which I'm sure are going to be handy in getting the practice back. Are there any comments from any of the panelists? Anybody would like to speak? Vardhaman?
Dr. Grewal should speak here. He is best qualified.
Dr. Grewal, sir.
Hi.
Sir, you have to unmute.
Can you hear me?
Yes, sir.
Thank you so much, Dr. Safali, for an excellent presentation, but a superb presentation covering all the different aspects of marketing. I'll go to one basic issue with the marketing at the moment. I'll go to the basic issue. Should we market? Should we need to do marketing? And why should we not able to have good patients coming to us without marketing? If I look at my last 20 years of record, and we have tried everything in marketing, full page advertisement in the newspaper, and radio FM, everything. What has worked for us so far is word of mouth marketing. And that is what over the years, my more and more faith and confidence is going into it. We have been monitoring our advertisements and comparing it and preparing graphs between the patient footfall, the phone calls, and see how the effect is coming. The newspaper advertisements will bring a good number of phone calls, and the effect lasts for not more than 72 hours. So the investment at this moment, I know the people in the region will know that we have not advertised for last 4 years. Not at all we have advertised for last 4 years. We are putting all those efforts, all those money to give an experience to those who walk into our premises. And that is what matters. And today only I was thinking about our LASIK patients. You see, sorry to say that, but I had very little complications in LASIK. I don't have anything to say about LASIK, but whatever complications I had were during our campaign of LASIK at 999, right? That would bring in patients, and whenever there is extra rush than what you are able to handle, then your system breaks down. So your system should be geared to the volume of the patients you are getting. So if you are doing let's say X number of cases and your advertisement brings 2X cases, are you geared to give same kind of a patient experience to that? So that is a very philosophical way of looking at whole of it. Where do you want to go? Are you going to go into for volume, short term? Every advertisement brings a spike. How many of them come back? And my experience with LASIK has been that whenever we advertised, we had good number of cases coming. But those cases, when we go through the data, they never came back again. They came, bought potatoes at a cheaper price, and then went back there. So it is a long-term image building exercise. Marketing should be a long-term image building exercise where you don't look in weeks and months, you look in decades. What is my marketing plan for next 10 years? What is my marketing plan for next 20 years? Where do I want my brand to go at? Where do I want? Because you see, the reputation is something which lives in people's heart. It's not your possession. My reputation is not my possession. My reputation is the possession with the people's mind. Now that is with those who have experience. And that is what I have realized now after so many years, that what matters is how you market yourself within your premises. And I'll again thank Safali for a fantastic presentation and very good way of looking at the marketing. But then there are different perspectives of looking at it.
We completely agree with you, Dr. Grewal, which is why even us at Shrophi, our focus is our staff, because they are the ones who are going to be speaking to you. See, you as a doctor are not available for your patients all the time. So when the patient thinks you are available for them anytime. So even after LASIK, for example, or after SMILE, when they want to speak to the doctor, there should be someone who is very skilled and willing to and available. And that is why all our efforts are more on internal marketing and it's more on conversion. So we plug in the leaks. So we don't really focus on trying to gather too many patients. Like you rightly said, it has to be within what your infrastructure can cope with. But most important is to start at home. So it has to be by training your staff, and your staff need to know what you are doing.
And I also like that you didn't use the word lead generation. You emphasized on two words: lead management and lead conversion. Correct. And both these things happen within your and that is very important, that how you handle. And as far as the counsel's role is concerned, now very important point is, when do you hand over the baton to counselor? As a doctor, if the patient comes to me, I have to find out when is it the sweet spot when I hand it over to the counselor. If the patient has too many unanswered questions and I send it to the counselor, patient will say, "Yeah, doctor, mere time nahi hai." So there is a right time. You have to prime the patient and prepare him to be ready to go to counselor. Don't send the patient to counselor before patient is ready to go to the counselor.
Absolutely.
Yeah, I think I will, of course, with Sir's experience, I will fully agree with what Sir has said, and with Dr. Pupila also. Although I think the practice that me and my wife has built up is relatively newer. We are 6 years now into practice, but from day one we went with SMILE because we were very sure that this is something that our patients will really trust us with. And I think, as Dr. Safala also has said, that it is important that you have all the platforms with you, so that you're not actually saying that you do only SMILE because we offer only SMILE. So we in fact have kept including Contura. So we have kept LASIK, bladeless LASIK, Contura and SMILE, all of them. And my go-to strategy is actually, I tell them that you are a good candidate for corneal laser. That means that you can undergo all the 4 procedures. So it is up to you to choose. And then actually I tell them what are the advantages and disadvantages of each. I do also tell them that if it is smile, then although if I look at my results right from the after first 50 or 100 cases, I think they are at par with LASIK in terms of the early visual recovery. But I still say that there may be slight delay in recovery, if at all, with smile. So you have to be slightly patient with that. But if it is my family, I will probably choose smile because it is flapless procedure. I don't want to worry about and deal with the flap complications in the future. And second point about the internal marketing is absolutely bang on. I think, again, because although we are new, in that sense, we are only 6 years in this practice, I think our marketing budget has been dropping consistently over 30-35% every year, and practically to very, very negligible level, even though, again, we are a newer practice. Again, it is very crucial that we actually, let us say, we actually translate to the patient one USP of our center. So we should not probably say about too many things. So for us, what really works is two things. One thing is, as a family, we have been in refractive surgery for 35 years now. So we started in 1985. That really works for us very well. And second thing is having all the platforms under one roof. So we don't really push them for one technology, but we have intuitively seen that all patients, majority of them still choose smile because intuitively, again, in their mind, having flapless procedure is simply, let us say, easy procedure, more minimally invasive procedure, more comfortable procedure for them, and of course, more safer procedure. So I think that is what has worked for us.
I just want to make a point. I think a lot of us are blessed with decades of goodwill. So let us not take away from the fact that Vardhaman, you have a Contura is the power of digital. You would not have bought a Contura otherwise. Okay. So the point is we have to give a reality check. Just because we want to continue our good practices, we cannot be taken for a ride and the level field be tilted. Okay. So it is an equal opportunity world. We are all blessed. A lot of us are second generation, and Dr. Garewal sir, you have a brilliant reputation in Chandigarh, and even if you don't advertise, there will be people who will seek you out, and even Google seeks you out. So that is legacy. But it is a VUCA world. We have to take cognizance of the fact that we have been forced to buy machines or communicate in response to something which is spam. So to counter spam, let's be aware and be authentic. Marketing is a lovely word, and so is business. I think let's acknowledge that. We're all entrepreneurs. Anybody who's running a private practice is an entrepreneur. So, sir, I think, and I was also getting very bad leads. That's your web agency fooling you. We switched our web agency. We're getting fewer leads, but high intent leads. So there are different leads. There are people who can fool you. You have to, again, analyze. And now the new word of mouth is actually Google. So it's not that we're moving away from word of mouth. The word of mouth has moved away onto the internet. So I would just wish to say that in a way, we're all privileged. We were able to afford technology, and we had a goodwill that we can ride on. It's not easy to create that for somebody else to take 20 years. So I would wish to give the message that it's a ride where the more energy you put in, you do get results. And sometimes all of us are not as privileged. I'm blessed to be one.
I fully agree with you, Ritika. I would just like to repeat one sentence which Kankriya had said. He said that if I have to get a refractive surgery done for my family, I'll go in for smile. Now that one statement sums up everything, and that line is the essence for the whole of the webinar today. And this is what is the deciding factor. You see, a lot of colleagues in the region, when they have a family member for surgery, they'll come to me, and when they have to refer a case, they'll refer it somewhere else. Now that ambiguity should not be there. I would, if I am under the microscope and what I want to be done, I would like the same to be done for the patient. Somebody once asked me, sir, how do you define a good cataract surgery? Now it's a very simple question. And somebody asked me that how do you define a good cataract surgery? And my answer was that when I see the patient next day, and from my deep inside comes that, oh God, if I need surgery, give me a surgery like this. That is a good surgery. So you always put yourself that, okay, if I had to get a smile surgery, what should I do? And I want to do the best for the patient. And I 100% agree with everyone, and everyone advised me don't stop LASIK. Right? I may be the only one, but then there were a lot of reasons. I want to give my patient the best that is possible. So it was not a good business decision, but it was a good decision which has given me peace of mind.
Dr. I just request you to communicate that to patients, because there are a lot of patients who actually come to us, particularly in Delhi, with a lot of miscommunications. For example, that there are other technologies which are more advanced, etc. So I think it is our duty. We should not misinform, but as surgeons who know the truth, we have to correct the misinformation. That
is systematic misinformation. That is systematic misinformation. So
sir, it's time to call out things.
I understand. We've been trying to do that. I just wanted to chip in here to what Dr. Grewal said. And, I'm very lucky in that way. Actually, when I have to tell my patients, I can easily tell them I did smile for my daughter and son both over the last 3 years. And, that kind of gives them that confidence. And frankly, both have done extremely well, and I was confident of that. So that sometimes that thing also works a lot. Yes.
Okay, so we have, that was a great discussion, I think, on practice. And we have the last talk of the webinar today, which is going to be given by Ms. Anje Weber. She's a practice development manager for Southeast Asia at Carl Zeiss, and her topic is practice development during and after the COVID crisis.
Oh, good evening, everybody. Can you see my presentation?
Yeah.
Okay. First of all, thank you so much for the opportunity to be here today. And I really enjoyed the discussion, and I really pretty much enjoyed the last two sessions as well, because it highlighted pretty much that awareness is super crucial. But of course, even though awareness is created, conversion is key as well. Yeah. So I really also liked the point of being with emotions and benefits rather than going for price. Yeah. And my topic today, I hope it's complementary. It's about practice development during and after the COVID crisis. And this is actually a topic which we could talk now for hours, but I will make it short and crisp. Yeah. And I would like to start with a small quote. Yeah, because this is times of crisis, and the pessimist complains about the wind, the optimist expected to change, the leader adjusts the sails. And you, the clinics, I know you are the leaders, so you adjust the sails. I will much focus here on the awareness part, on the marketing part. Very important, first of all, I would really encourage you during this time to take frequent pulse checks of your target group, which is rightly said between 18 to 40 years old. Let's talk about optimism first. Yeah, I had a look, and very nice to see that when it comes about the optimism about the country's economic recovery, yeah, India plays pretty much up on the positive field, which can be a very important factor when it comes to elective surgery. That SMILE is. Yeah, it's not like the other countries which are really going very negative. Yeah, so this is a very, very good point. On the other hand, it's very important, and I always stress that with my clinics here in Southeast Asia, there is a huge consumer behavior change ongoing, and we all know, and you have heard it, there will be things that will stick. Yeah, they will not go away. There is a shift in the consumer behavior. Yeah, so even though actually our target group is more prone to unemployment, but the target group we are talking about, they're also very well adapted to this remote working setting. Yeah. So in terms of shopping on consumptions, their preference, and this is especially, I looked it up in India, very true. Consumers even the younger generation is really going towards the trusted brands, and Smile has a proven track record. The technology is proven and trackable. You can show it in your clinic, you can explain it, you can create or raise awareness, as we also try in ZEISS to raise awareness. And even better, if, like what I just heard now, your clinic has history behind and is proved and is trusted by your consumers. Yeah, another big trend of your customers, because now life really becomes life at home. We work at home and we live at home. Yeah, so there is this huge searching online. We have done multiple web conferences, and with this goes hand in hand that we have also a different timing now in place. We can most likely go for an appointment, for example, for an initial screening, because we can adjust now better. We don't have much to commute right now. So we can allocate our time better right now. And on the other hand, a lot of people are also thinking about their whole life. And this whole situation has brought up one topic very much, which is YOLO. You only live once. Yeah. So if you only live once, what would you do? What is your wish? Do you really want to sit in front of the computer when you have your conference? Do you really want to put on your contact lenses there or sit there with the glasses? Or do you want to experience the freedom to take your freedom, because you have the choice? Right now, a lot of things you don't have a choice. There is freedom restricted. But this is something that I can choose to change. Yeah. So if you play around this in your marketing, this will certainly pay off. Also, another very big trend now, with all this crisis, there has been a major shift into healthcare and hygiene. Yeah. A lot of things happening or going on with the contact lenses as well. Yeah. They are more open now to e-consultations, and with this whole shift that we are now at home, we are bound, we cannot travel. A lot of people don't have the expenses that they might have if this life would have gone on normally. So they might not spend in traveling now, which most likely will be a huge chunk in this year. So how can they allocate, or how could they allocate this? Investing in themselves. Yeah. And that's why I really urge the clinics to reassess on how and where do you approach and you connect the customers or prospect when it comes to awareness. Not taking apart that, of course, conversion and referral plays a very crucial role as well. Yeah. So really reassess if you have in-house marketing or if you work with an agency. Where do you have touch points with your prospects right now? And I can really tell you that this really pays off. And even though we just had now the discussion on should I really invest now in marketing or just freeze it for now a little bit, yeah, I can tell you I have proven examples here in Southeast Asia where they really started very heavily into marketing and connecting targeted with their customers, be it with Facebook Live, Instagram Live, getting closer to them. We heard before getting authentic. This is very, very important, being authentic and giving them information, bits and pieces, and getting them down the funnel. Yeah. So this is really, really important. And despite this whole crisis that we have, there are industries which are related to elective surgery, for example, plastic surgery or cosmetics. And last week I read a very interesting article that in a country, it was the US, actually there have never been done so many facelifts like in this summer. And the pure reason that most of the people come is They have doing all these Zoom calls, they have been in conference, and even people who used to work in the back end, they are now forced to step forward and be there. Or students who used to go for an interview face to face, and now they're getting interviewed for a job online. So of course they want to look their best, yeah? So there is kind of a paradoxical thing going on that I really like this one. The world is shutting down. We are all worried about global crisis. The economy is completely crashing, and people come in and they still want to feel good about themselves. And why is that? Because this is something that we have in our control, yeah? And I really want to care for myself. And if I can fix about my eyesight, then I will reach out. And this is now really a very good moment to get into this and to reach them, raise awareness, educate them, bust the myths, what we just heard earlier, and small little video clips, for example, because our target group really likes to consume small little pieces, and on top of that, Google ranks videos very high and brings them up first. So I would really encourage you to get in touch with them even more now, be on their side. You can even raise questions or help them to take care of their contact lenses, yeah? Have a talk about contact lenses and how to take care of. And of course, you can then pitch that there are other options available. But basically, support your customers, your potential prospects, be on your side, and there is even the potential to reach new customers during this time, as everybody now is even more on the social side, and everybody spends even much more time now on social and in the digital world that we have been done before, yeah? So one important factor, of course, in the clinic, and I'm pretty sure you all stress that very much, is keeping your patient healthy and safe. Why do I stress this here? Because if you do so, of course, you should broadcast that, yeah? You let your people, you let your prospects know that you are doing this. You can do small videos. You can show how you do that. You can show how right now is a real consultation if you come in, yeah? Definitely, you have to space out. I'm pretty much, you are doing that. And if you give your prospects reassurance that you take all the measurements beside being a trusted brand, that they know you, that there will everything be okay, you will be cared of, then they will more likely to walk into your business, yeah? And if you have done so, or maybe you're considering online consultation as well. With the prospects, of course, there are some changing. As I said, workflows have been changed, the work itself has been changed. A lot of people are even reconsidering being it forced or reconsidering their whole life concept, yeah? And one thing that you can do, for example, is you could consider expanding your working hours, have a happy hour afters. Here we have clinics who have started to open on the weekends, yeah, because a lot of people are very busy now, and now nothing much to do on the weekend. So yeah, why should I not explore that, yeah? And of course, these people have been funneled down via some Facebook Lives, maybe a webinar, maybe an online consultation, and of course, through conversion in the clinic, that all the leads get really followed up properly and no lead gets lost, yeah? So I have also clinics here who do actual test of COVID right before the surgery, like 3 hours before. I'm not sure if this is even possible or allowed in India, but this has worked out quite well. And they have broadcasted on all the channels, yeah, simultaneously in various ways, and not only once, because you can change the message, but you display the same message in a different format, yeah, throughout time. So basically keeping in touch with them and really give them the idea that this is the right time to do it now. And here are some small ideas, yeah, what we just heard a little bit as well. You could do subscription campaigns because you might have cold leads, yeah, when you were closed, you could send some re-engagement mails, because a lot of times clinics forget about these cold leads that once were interested just by a phone call or they visited your website. Get or try to get in touch with them again. And this can be very inexpensive. This can be through email, this can be through a messenger system, and you're just offering them an initial screening, yeah? Or you can offer them a self-test if they're suitable, and then you offer them an initial screening, yeah? So the call to action is online booking, yeah? Also another thing, online booking. Yes, phone is great, but the convenience, especially of the millennials, I want to book it now, right now, and I don't want to even pick up the phone, yeah? So another possibility, of course, awareness campaigns, yeah? So this is about Google Ads, and we heard about already Google is very powerful. We all know that reviews are very powerful, and you could actually also play with YOLO, with the fear of, or with the fear of missing out. Yeah, you could also do things like maybe you are not the right candidate, or isn't it right for everyone? Yeah, and then you get people curious, like, why should I not be the right candidate? And then you get to make them a self-test, or you make them a suitability test, or you make them to call you up. Yeah, so I would suggest not cutting right now on Google Ads, but refocus. Like I said, have a look. What is your target group right now into it? What is of their concern? Talk to your agency, talk to your marketing, and target it. Spend the money wisely, yeah? Because right now it's not the time of big marketing budgets just being spent like that. It's about being targeted. Engagement campaigns, how can you engage them? The ones who have visited your website, the ones that have been visiting your Instagram channel, ask them to follow you if they have not. I mean, we can all see this now in the back end. Instagram, Facebook, they have great analytics tool. Look them up. Even look up whether you have the right target group, whether you have the right people following you on Facebook. And like what was pointed out before, right now is a great time to reassess your website, to make your website better, to make your online presence better, to invest in getting reviews, to reconnect with patients that have underwent SMILE successfully. Yeah, so it's utmost important that you provide value, that you are close to them, yeah, that they can feel you close to you, that you have engaging content. Yeah, this could be even a coloring contest or a sweepstake, that you are entertaining, that you're not just crossing the message, SMILE is the best that you can do for your eyes, what I'm sure that you are not doing, yeah, but be entertaining as well. And all of this, before I end my talk, I would like you to really recommend my colleague, which is Lohit Shetty, who runs the practice development program in India, as they have a full bag of awesome packages or programs available, which really runs through the awareness, to the conversion, and then to the referral and back. Yeah. So if you're interested, I can just strongly recommend you, because this will for sure help your practice to stay strong and navigate well through these times and beyond COVID, obviously. Thank you very much.
Thank you so much, Ms. Anje Weber, for doing that great presentation. And if anybody would like to comment on the webinar, Ritika, would you want to say something?
I think they were very valid points that were raised. And the most important, of course, that all of us can together work on is creating good video content. While working on our website, I think good video content is something that, I mean, I have a 9-year-old son. He doesn't read. He knows everything because he watches it on YouTube. That's how this generation works. They don't write, they type and they dictate and they watch content. So I think it's time to realize that that's what is the future. So instead of writing and giving content, it's time to create videos. And vernacular languages work very well. So I think Hindi content, Marathi content, or any language content also has to be given attention.
I totally agree. And I also, my daughters, they just very bit-sized videos don't make me read. Make me watch a 1-minute video and I get it. And talk talk in my language, what you also pointed out, my language. Don't talk technical stuff, talk in my language and what I want to have, create emotions in myself in order to call you up.
Also, I think it's important that they are the attention span is quite small.
Yes.
So it has to be precise, it has to be hitting the target and not really beating down the bush. And then it's good to see you. Lovely talk.
Good to see you.
I just wanted to ask you, do you see a revival of refractive surgery volumes? Are they picking up in other areas also outside India?
Actually, I can tell from the clinics here in Southeast Asia. I have clinics who had the best months ever, and it's not, I mean, ever since opening, and they have been around for a long time. But you could say, no, it's just the backlog, yeah? But it's not, because the funnel is not running dry, yeah? They are working like crazy because they really invested now during this time, because we also had a lockdown here, and really get in touch with them in new ways, like exploring IGTV, etc., and going all these new ways, all the channels, because people, I mean, even I do it, lunch break, I go social, yeah? And when you can see there's something new, maybe you get interested, yeah? You need a nice hook, which is not, I totally agree, which is not the technology, yeah? Technology benefits, yeah? And of course you can play around with size, being around for a long time, etc. But you have to really watch what are they interesting in. So for example, I saw here a nice ad where a wave is coming to the shore and basically it says, your vacation is washed away, sorry, but hey, there are cool things that you can do right now, yeah, now that you have the time, and then you can recover, yeah, so be creative, small gifts, small videos, yeah, so this can really help to connect in a real way, and not in a very superficial, high glossy way, in a real, authentic way to your prospects.
Gaurav, would you want to say something?
Yeah, I think I would just want to say here that, the message is loud and clear. I think Smile has come a long way. The technology is amazing. All the top surgeons who are using it are all very satisfied with what they are doing. So I think patients are very happy. And I think excellent talks in the end for this. So I think today's webinar has been really productive in that sense. And, I think take-home message for the audience is obviously loud and clear.
So I think we would conclude the webinar if nobody else wants to add anything. And I think we've had a great webinar, and the science and the commerce part of it actually have come together. And we would like to thank Dr. Mahipal Sachdev for conceiving this webinar, for putting it all together. And also like to thank all the panelists, all the speakers who did a great job. Each of the talks, had a learning, had so much of learning. It covered everything about Smile, and also how to restart and how to energize Smile in the COVID era. So I would like to thank all the panelists and the speakers, and I would like to thank Zeiss for supporting this webinar, particularly Mr. Deepak Singhal, who has been coordinating this webinar, and of course Mr. Lohit Shetty, who's also been a part of organization, and Mr. Arun Shetty, and all the members of the team of the Zeiss company. So thank you everyone, and thanks to the team of audiovisual, which is at the back end. It's more than 3.5 hours webinar, and they are still at it. Mr. Sunil, Mr. Kripal, Ms. Rakhi. Thank you very much for staying over and for letting us be there. And this content is going to be available on the Facebook, on the YouTube, as well as on our web browser. So thank you for your great contributions. Thank you, everyone.
Thank you.
Congratulations,
Thank
Dr.
you,
Namrata and Dr. Maipal, for yet another wonderful program for AIOS.
Congratulations, Dr. Namrata. Well done.
Rupal,
Really nice.
smile we have learned in India because of
Absolutely.
Dr. Rupal. She's the she just is the epitome of smile procedure. And when it came first, we probably were not convinced. But I still remember the refractive surgery day when Dr. Rupal presented many